and today we are going to do the last day, the day two of the discussing, and we'll be discussing today on the metastatic breast cancer, and we will be looking into the important abstracts from ASCO and ESMO Breast 2026, not ESMO, actually ESMO Breast 2026. And without wasting much of time, I would like to invite Dr. Vamsi Krishna from AIGA Hyderabad, a dear friend, and he'll be moderating on and looking into and discussing two trials, the Victoria and the Persevera, and he'll be and this is in the advanced hormone positive breast cancer, and the discussants will be Dr. Saurabh Mishra again from AIMS Bhubaneswar, Krupa Shankar from Coimbatore, and Dr. Chetan from Pune, and Dr. Vishwajit is again joining us today from Puducherry, JIPMA. Vamsi.
Good evening to everyone, and thank you, Dr. Sahu, for having me here. So I can see
Can you
both
please
of
share the slides? Pooja, can you please share the slides? Yeah.
and I can see Dr.
Please.
Vishwajit and Dr. Saurav here. Dr. Krupa
Yes.
has joined, and I think Dr. Chetan also. I saw him around. Dr.
Yeah, Chetan is there, Krupa is there, Saurav and Vishwajit. You have a full house.
Wonderful. So continuing this deep dive that Dr. Sahu has started, and it's the fourth deep dive. So, it's kind of amazing. We're already in the fourth year of this. So what I will do over the next 30 minutes, maybe around 10 minutes, we will just discuss the Persevera. 10 minutes, we will discuss the next trial, that is the Victoria. And around 10 minutes, we will discuss how these trials impact our management in India and how we are actually managing patients in India, right? So next slide, please. So the first study that I'll be highlighting is the Persevera. Now, Persevera is actually about the giredestrant plus palbociclib versus letrozole plus palbociclib as a first-line therapy in patients with ER-positive, HER2 negative. Remember, there's a first-line patients. We did hear a lot about giredestrant in the adjuvant setting last year and in the metastatic second-line setting. This is the first-line setting. So this small cartoon is taken from Dr. M.B. Chandrakant. I was very happy to note that his cartoon was the first thing that came up on my Google search. So Chandrakant, if you're listening somewhere, good job. So yeah, Google recognizes your good work. So no prior.
Actually, Randeep yesterday also picked up a cartoon from Chandrakant. So
excellent.
good.
So Chandrakant is doing great SEO work. If or else he's Google likes Chandrakant.
Don't tell Amol about it. Huh?
So Gira plus Palbo versus letrozole plus Palbo. Next slide. The important thing to remember is these points. It's a no prior treatment for advanced disease. Disease recurrence more than 12 months after the prior AI or tamoxifen. Disease recurrence less than 12 months for patients who are receiving only neoadjuvant tamoxifen. Now, this was an initial protocol, later not given. We don't know the details. The final paper hasn't come out yet. So they looked at Gira plus Palbo versus letrozole plus Palbo. Now, interestingly, it's a blinded study, so they used a placebo in both the arms. So you essentially had three tablets in each arms. Treatment until PD. Next slide. Looking at the statistical design, a very modest design. The primary analysis, they wanted to detect a hazard ratio of 0.77, which is actually not much. And the statistical significant boundary for efficacy was actually 0.85. So this is not a very big thing. So Dr. Vishwajit, if I can start with you, since you're my first on the screen. Was this a very realistic study? Because, they're not looking at a very big hazard ratio. They were not looking at a 0.6 hazard, 0.65, 0.77 is not a huge number. So trial-wise, what do you think of the design?
Yeah, I completely, I think, agree with you that usually when you look at, I think the whole idea was, I think, based on these sample calculation, sample size for the study. So that's how it's adjusted to quickly finish the study probably. It's a very poorly, again, designed. It's like any other Palbo poorly designed study, I think, previously also. So yeah, 0.77, 0.85 does not look very impressive to me.
Okay. Dr. Saurav, your thoughts on this? 0.77, you're not being very ambitious here, not looking at a huge difference. What's your thought on the design?
So, sir, basically, if you see in the treatment options in the front line, so there is again another trial which was a negative trial, that was the Parsifal trial, fulvestrant with the CDK inhibitors in the front line compared to letrozole, and there was no significant difference there. So, having said that, probably this is another molecule which has been successful in multiple other settings, but probably this was not the most appropriate setting to be seeing this drug
Okay.
in this.
Krupa, what is your thought? When the adjuvant trial came out last year, we had headlines: 25 years, 30 years, first new you have a endocrine option after so many years. So was this reasonable? 0.77?
I think, like everyone has rightly pointed out, you're talking about a 23% relative risk reduction, but powered at 89%, close to 90% power. So I think that's probably, they were not probably too ambitious or greedy
Oh,
enough about
very,
that, and they were probably okay with just expecting a sort of a minimal advantage with the combination, which is
well,
why
I think
probably they went in with the other.
so. That's what Dr. Atul has mentioned, that it is reasonable that you don't expect a huge jump over AI. So it was a reasonable number. That is not bad. So this is what he's also
But
commented, that the
would we use the drug with such a minimal benefit is the question.
so
If
that's
you
what
are
we'll
not
have
at all
to.
looking at, so would you actually?
Absolutely. So that's exactly why I was bringing about this point, that if you wanted a higher difference, you would have had a smaller sample size, actually. That's what my understanding is. But they have gone with a modest thing and they did take a reasonably big number. So that's my understanding on this thing. Next slide. So this is the patient demographics. Now, interestingly, the perimenopausal and premenopausal is only 20%. Postmenopausal is up to 80% of the patients. Mostly ER positive, more than 10%. Some trials have used more than 1% as well, but here they stuck to a very, very good thing. Then they also looked at if you look at the overall the requirement, previous adjuvant therapy was given in around 80% of patients. Previous neoadjuvant therapy, 34% was with AI alone and 20% with tamoxifen. So overall, not a very aggressive population. Next slide. Why this becomes important is later on. Then when you look at the PFS actual results, 33 months versus 28 months with a hazard ratio of 0.89. Remember, I told you that what they wanted was 0.77, upper boundary would be 0.85, and nothing met, 0.89. So p value not met, nothing. So it's a negative study. Next slide. Look at the OS. It's like the lines are just sitting on each other. So this is the result of the Persevera. So next slide. Yeah. So Dr. Chetan, looking at this result, no, it's a negative study. So it's rare that we get a such a negative study, but with Gira being what it is, no, can go back, please. I'll ask one by one. Can go back. Slide. Yes, go back. Go back. Yeah. So Dr. Chetan, your thoughts on the study design and on the result. PFS negative, no benefit.
Yes, I was actually disappointed to see because just yesterday we discussed Lidera and it showed an impressive result. And pairing it with palbociclib in the metastatic setting would have been the most logical step. Though they have kept at their expectations were not very high. I wanted those expectations to be met because they were not very high to begin with. So and hazard ratio of 0.77 wouldn't have been difficult given all the other advantages of giredestrant. But yes, this is what we have, that it is probably paired with palbociclib. And well, I have no issues with palbociclib per se, but I'm still disappointed that it did not meet its desired end result.
So I will come to Dr. Sahu's question to Dr. Atul and bring him on this discussion regarding the sample size. But before that, next slide, please. Dr. Bishwajit, you agree that Palbo is okay. Remember, we have now in a metastatic setting no OS advantage with Palbo. Abema and Ribo have both shown OS. Would it have made more sense to pair it up with one of them? Or as someone is suggesting, Palbo not so important, so better you give it with a not so powerful drug and see a difference. Is that why Palbo was chosen?
See, I think the trial is on the hormone sensitive diseases because we are using letrozole. and we are not looking at a good biology disease, probably not having too much of those ESR1 mutations. Anyway, upfront study, you will not be looking at ESR1 mutation.
Correct.
And we all know that the certs work very well if there is an ESR1 mutation and if they're a little bit resistant. That advantage probably is there. Only then it works. Even yesterday's, when you see the adjuvant study, the difference is not much. 2%, not a very changing trial. I think here also it's the same story. I mean, they have taken it because obviously letrozole has been the control arm drug, so it has to be a hormone sensitive disease. I think that is where the issue probably lies.
Okay. Saurav, your
Because
thoughts on
hormone
this?
sensitive.
They use
So, sir, basically, they were trying to find out. So, if you see, sir, both Abima, Ribo, Palbo, all have the hazards ratio 0.5 if it is for PFS. Response rates are absolutely the same. So, probably what they were trying to find out, can they combine something else with a CDK4/6 inhibitor? And so, majority of the patients probably at that point of time were using Palbo, and therefore they changed letrozole versus. So, if they would have used Abima, Ribo, I don't think the results would have been different. So here it is, what is driving the benefit is probably the CDK4/6 inhibitors rather than the letrozole or the
Okay.
SERD.
So Dr. Naresh has made a point that they said that Palbo has these side effects. I'm not sure I completely agree with that statement. Palbo has its own set of problems. So I'm not sure if Palbo alone has this thing. So Dr. Chetan, you're saying about the OS and saying that only the OS was different, PFS was similar. So you're okay that Palbo is used instead of Abima or Ribo.
And in spite of PFS being decent, remember all their PFS had a hazard ratio around 0.54, 0.55. Yeah. So with the original CDK4/6.
Yeah.
In spite of that, here the PFS also has not been met. I mean, OS is the bahut dur ki baat, but even PFS is not met.
Correct. So again, next slide. So Dr. Chetan, since you're saying this, the original Palbo arm had around 23, 24 months. Ribo is around 25, 26, somewhere around that. Here it is 28 months. Is it because you overperformed? Is that why you don't have this result? Or, we look at the composition, mostly postmenopausal, good, strong, ER positive, very few pre-treated. Is that why this arm has done so well?
Yes. I think that is you have 80% crowd which is postmenopausal.
Correct.
So no ganjet of ovarian suppression and all that. Just the 80% crowd must have gone on straight away on one of the two arms.
Correct.
Plus they have, most of these have an ER which is more than 10.
Correct.
So significant. Low ERs are less than 10%.
Correct. Next slide, please. So Krupa, your thought on this.
Yeah.
Is this approach correct now? You combine a SERD with a CDK4. Sort of talked about the Parsifal. Not great.
Yeah.
So is this the right approach now to combine a SERD with CDK?
I think unfortunately in the first line setting doesn't seem to be the right approach, number one. And number two, the Parsifal was again phase 2 data. It was not phase 3.
Yes.
Again, when you talk about the adjuvant setting to do the metastatic, when you talk about lidERA versus persevERA, lidERA, I think one of the criticisms was they did not have an adjuvant CDK6 as the control arm. So that was one of the probable caveats there. Because right now we know adjuvant CDK4/6 is probably standard of care. It's been established. And I mean, like, again, for me, I think definitely not based. This is not a practice-changing data for me as far as I'm concerned. And I wouldn't really look at using a SERD right up front because that probably affects my sequencing strategy in the clinic. So I think absolutely not, as
Krupa,
of right now at least.
Yeah. Krupa, if I can ask you the EMBER study. EMBER included IMLU plus Abima. And IMLU plus Abima did do better. So, that tells you that probably a SERD
again,
plus... Yeah. Go ahead.
Again, the EMBER, if you look at the ESR1 mutated population, the magnitude of benefit was much higher, Vamshi. So again, if you look at the overall intention to treat population, the benefit was not as much as in the ESR1 mutation. So horses for courses, I think if somebody's got a ESR1 mutation, yes, but otherwise, not so inclined to do that in practice.
No, I was speaking of AMBER versus this trial. I think it will be very unfair to compare both because the patient profile is so different for both the trials.
I'm not comparing EMBER with this. What I'm trying to say, Dr. Sahu, I was saying IMLU plus Abima did well there. So is there still a combination of a SERD with a CDK?
I was coming to that only. Look at the inclusion criteria of the patients for AMBER. They had a much more bad profile of patients than what this disease is. So, and you have only 10% of patients in this trial who had failed within 1 year of stopping the endocrine therapy, and 20% were treatment naive. So basically, this was more of a patient whom you don't expect a ESR mutation to happen. So I think that is the basic difference with Amber versus this. This is my thought. I think you are there, the panel is there, Atul is there, others are
Yeah,
there.
so
They can also comment on
So again,
yeah, if I can,
yeah. So who? Yeah, somebody is telling. Please go ahead.
Krupa is saying something.
nothing.
Yeah, Krupa.
Yeah, nothing. So if I could just chip in with that. So I think if you're talking about the rationale of combining both, yes, probably, when we discuss the next study as well, we'll realize that the rationale is there to combine both, but probably not in the first line. And I think that's where, the caveat is.
The setting is
Probably,
probably
you got
wrong.
to look at
It has to
selecting
be in the second line where there is some mutations with the ESR1, not in the adjuvant setting, not in the first line setting.
So Evera showed that exactly. Evera showed that if you could combine in the second line, that's where you're getting the benefit. So IMLU was in a different whole setting. You had prior CDK used there. So many other things were different. So that's not what I was getting into a comparison between the two. So let's stop there. Next slide. So again, this is where I am asking everyone, all the 4 panelists, after this study, is there any patient in the first line where you would still possibly want to use a SERD rather than a normal AI with a CDK4 inhibitor? Krupa, any patient where you still think SERD has an option? Dr. Sahu has raised a point that in those patients who relapse within 12 months, there's a new study going on, which will come later, hopefully. It has not yet been published. But currently, if giredestrant is launched in India, any patient in the first line you would want to use this, or you think it can be used?
Not really, Vamshi. See, I would probably be more taken with the Inavo 120, the
Inavo
plus
is
fulvestrant. Yeah,
Inavo
if
is a
at all
different.
somebody's got a big 3 mutation. Correct.
Fair enough.
Somebody's got
Inavo
a
is a
big 3
separate
mutation
trial
within 1
altogether.
year. Yeah,
Yeah, absolutely.
correct. But so,
Next slide.
so not for SERD in the first line. I mean, like, definitely not as far as right now is concerned.
Next slide. So again,
Somebody with
interesting.
sorry.
Yeah, go ahead.
Somebody with a bad joints, bad osteoarthritis or osteoporosis, probably, because giredestrant seems to have better compliance.
Okay.
There
Next
may
slide.
be, but that's a very small subset.
Okay.
Otherwise, not really.
Next slide. So this is what I wanted to actually look at, because exactly what Dr. Chetan said. Is it there a better tolerance somewhere? Next slide. And if you look at this study at least, there was really no difference. So, this whole idea that giredestrant would be better tolerated is actually not there in this study. Again, there is some data that in adjuvant, maybe if you're giving 5 years, it makes a difference, the tolerance and joint pains and all, but at least in this study, it's not there. So even that one subset is not seen in this trial. So I'm not sure if what you're saying, Dr. will matter. And again, I think if it's launched in the first line, this is not somewhere we are going to be a patient, at least for first line. Dr. Bishwajit agreed that first line, no giredestrant, even if it is launched in India. Dr. Bishwajit?
Yeah, so I think.
Yeah. Krupa, go ahead.
Yeah, Vamshi. Yeah, I agreed with you. Even Rosh may not be happy. Rosh may not be happy with what we're saying, but I think absolutely not forget this in the first line setting, at least for metastatic breast cancer.
Dr. Sahu has made sure that Rosh is not there to be unhappy or sad about, because he's made sure it's a purely scientific discussion. Next slide, please.
Exactly, that's the best part.
So this is interesting. Adjuvant lidera, positive EFS, metastatic second line Evra, positive, but first line, unusual to get such a result. It kind of brings to picture the whole role of SERDs in the entire treatment, because where exactly do you position them? A very interesting space, I can say, in the last 1 or 2 years. So that will be my last word on this study. Next slide. Let's go to the next study. Okay, before that, any of the panelists can take this. Oral SERDs, are they going to be the same? We have giredestrant, elacestrant. Are they going to be same? We have elacestrant, we don't have giredestrant. Anyone can take this.
So we have the data with elacestrant, at least in the setting of ESR1 mutations. And then we have another drug in the adjuvant setting, camizestrant. So appears that they are all active against if you have an ESR1 mutation, but per se individually, as we discuss about the CTK inhibitors, probably these drugs also have some nuances to discuss while we treat the patients.
And we know the Serena 6 story. I'm not going there, but it's a very interesting story again. Yeah.
Absolutely.
Absolutely. Next slide. So this is the elacestrant which you commented about, and I've always looked at this and been amazed the fact that other than these small subgroups, the PFS is actually 2.5 months. Hardly anything. Next slide. So I'm not going into elacestrant detail. Next slide. So this was the second study, Victoria 1, study 2. So next slide. We already had the gedatolisib last year, which was the Victoria 1 part 1 study. Now part 1 and part 2 are essentially the same. What they looked at is in part 1, all patients who were PIK3 wild type. Randomized 1:1:1 with an N of around 390 patients to a triplet of gedatolisib, palbociclib, fulvestrant versus geda fulvestrant versus only fulvestrant. Now this is, remember, a second line therapy, progression on or after CDK and NSAI. And remember, we had this discussion. Are we looking at fulvestrant as an inferior comparator arm because you're giving only fulvestrant? You're not giving any other, targeted therapy here. Now, the study 2 was done later, that was including only in PIK3 mutant patients. 3:1:3 randomization, again the same 3 drugs, but in the third arm, instead of giving only fulvestrant, they added alpelisib to fulvestrant. Right? That's the difference. Now, remember, alpelisib, when the original trial came, did not have a pre-CDK inhibitor. But here they mentioned that patients should have had a progression on or after CDK4 inhibitor. So there's a difference between the SOLAR one and this study, which is something we need to remember. Next slide. When you looked at the study that came last year, the Victoria one, this was the result: 9.3 versus 2 for the triplet, and the doublet was 7.4 versus 2. So that sets your base for the PIK3 wild type group. This is not the mutation group. Okay? This is wild type group. Next slide. And this was the interim OS, again showing some benefit for the triplet as well as the doublet. Right? Just to remember these numbers. Next slide. Now we come to the present study, what we are discussing today. That is the study 2. This is in PIK3 mutant. 3:3:1 randomization, 360 patients. Triplet versus a doublet of gedatolisib and fulvestrant versus alpelisib plus fulvestrant. Okay, so 3:3:1. So straight away, Krupa, this jumped out at me. What is this 3:3:1? Any thoughts of why they had such a weird randomization?
So I think you're right in calling it pretty weird, but I think probably this is one way of getting more people to go on to the trial, because they were sure to be get randomized into one of those gedatolisib arms. So I think that's probably one way of how I would probably look at it.
I don't know the answer. I don't know. Maybe the final paper would give us more, or maybe the original paper has described it. I could not really find time to describe. But it's a 3:3:1 randomization, which is
probably they wanted
Is it because
these two arms to number
from
of
the
patients
previous
to be more on the
Is it
each
because
of
from the
the
previous
arms which
data?
they wanted.
Yeah, Dr. Bishwajit. Sorry, you were saying something. Dr. Bishwajit, you were saying something about the previous data.
Yeah.
Okay.
Is it because from the previous data which we have? Yeah. The previous data which you showed,
Yeah.
where we had the 3 versus the fulvestrant, which you showed the previous data. Based on that, I think the fulvestrant arm was anyway weak, so I think that's why they kept that combination. Probably may not work as good as the 3 drug together.
Again, I'm not sure of the reason.
The principal proof was there.
Yeah.
Not sure of the reason, but
it's
it's unusual for me.
Yeah, I think that was in the wild type patients, and this was PIK3 mutant patients only. I think that's why they included alpelisib as fulvestrant as well.
Next
they were
slide,
trying to
please.
probably compare this triplet versus fulvestrant alpelisib. Probably that is what they wanted, to have more patient in each of the arms rather than the fulvestrant that's probably one of the reasons.
Okay, next slide. So this was the primary endpoint, which is PFS. Again, they had a hazard ratio requirement of 0.56 for a triplet versus alpelisib. So it's a pretty ambitious now. We were talking of this. So if Dr. Atul is there, can I just get you in, Atul, on this? Because you were talking of the PFS and the numbers. Here it is 0.56. So you need less numbers to establish, more numbers to establish such a high, low PFS, the hazard ratio. Is that what you were saying?
If the hazard ratio is low, you would require a lesser sample size, because here the delta is what we speak always.
Correct.
The delta is higher, therefore the sample size would be lower. But it would rather be based on the drug activity as well. So like we
Also,
were
one-sided
discussing for giredestrant, it's a SERD versus
also.
AI, and you do not expect a very, I mean, dramatic kind of improvement over it because the baseline is also high. So hazard ratio is also kind of weird. So when we are comparing the 6 months with the hazard ratio of 0.5, then it increases by another 6 months. It goes to 12. But when you say it is baseline 24 months and you say it is 0.5, it will actually be 48 months, which is kind of, I mean, unrealistic for an agent like giredestrant. So I think the absolute PFS that you have as a baseline and sample size. Of course, industry would keep it always conservative than their expectations because they would not also want to have missed a lower impact as well.
Completely. So for those who are listening, this is why these numbers are set at
Atul, you are saying that for a hazards, let's say where like 0.56, you need a lesser number to
Lesser.
prove.
Correct.
Right,
It's
sir.
always
It is like 6 months versus 12 months broadly. And for a hazard ratio 0.77, it would be like 6 months versus 9 months. So to show a
Maybe
lesser
in your talk
improvement.
you can just put little bit because this looks little what I did think.
Atul,
It is totally
also
opposite.
this is one-sided and not two-sided.
Say that again, sir.
The study they have taken is one-sided and
So
not two-sided.
one-sided would decrease the sample size.
Yeah, will
So
decrease further
one-sided
decrease
is
the sample size.
okay if you are quite sure that it is highly
We are
unlikely
sure
to
that
go on
it
the
is
other side.
yeah
That is likely
on the other side.
unlikely to be worse than the comparator arm.
Correct.
So I will not
the
go into
one-sided
more-
probably also reduce the sample.
Correct. It will reduce the
Right.
sample size. It will. So let's go to the next slide. Now, this is what they wanted. Next slide. This is the way the arms are allocated. So if you see the middle arm, that is the one arm, it's only 52 patients. So numbers are not huge here, 150, 150. Like Atul is saying, because they look at a reasonably big hazard of 0.56, these numbers are enough for them. Next slide. So this is the result that they actually got, a hazard ratio of 0.51. It was met. 11.3 versus 5.5. Now, interestingly, when they looked at the triplet, when they looked at the PFS for the doublet, there also it was 0.51. When they looked at the PFS hazard ratio for the triplet, it was around 0.50. So the doublet and the triplet seems to do equally well, which is interesting because that means you're not adding anything by making a triplet here. The PFS remains the same. Next slide. But the next kicker comes in when they looked at the secondary endpoint of the OS. The triplet OS is slightly better, 0.76 hazard, crossing the unity, not very significant. But the doublet is actually inferior to the alpelisib plus fulvestrant. So again, this is the OS, remember, because OS interim analysis can change, but ultimately the doublet PFS seems to be equally good. OS is not there. Again, a bit confusing for me how to really explain all these studies. Next slide. Dr. Chetan, your take on this, because this is what the authors have said, that if you add doublet plus palbociclib, you're doubling a median PFS, which is fine and good. OS is not there. Multi-target PAM is more important, is what they're saying. Dr. Chetan, your take on this, because should we rethink our whole policy and say, okay, PFS is still very important, OS not so much, crossover was allowed, all those things are there in this study. So, what do you think?
So I think with triplet, it is very obvious that the survival is good, and that is what the drug is expected to do. It's a PIK3 mutant population, and you are adding a PIK3 inhibitor.
It
So
did not make
that makes
statistical significance. It's an interim OS.
true. Nevertheless, numerically the OS looks better. Numerically the OS looks better, but yes, I really am unable to find out why the PIK3 inhibitor plus alpelisib and fulvestrant arm, though having technically the same mechanism of action, has produced a worse survival.
Okay, Krupa, your take on this?
I think what's probably fascinating for me is the mechanism of action of this drug. It's a multi-pathway inhibitor, meaning it works on the PI3K, all the isoforms. Alpha, beta, gamma, and delta, all the 4 isoforms are inhibited, and mTORC1 and 2. So I think that's where probably the mechanism of action is slightly different. But I think probably the magnitude of benefit is definitely in those PAM altered pathway tumors. And as far as triplet versus doublet is concerned, for me, I think doublet is definitely good enough. If at all I were to use a triplet, I would probably look at changing the CDK4/6 inhibitor. That's how I would look at interpreting the data. And the OS data is immature. I think we'll have to probably wait for the data to become more mature before we comment on the OS. That's my take on all of this on this study.
Vamsi, can you come to the slide of primary endpoint for this?
Please go back to
Maybe
slides.
go back, please. Pooja, yeah, go back.
One more.
Go back.
This is the primary endpoint.
No.
PFS.
Just the primary endpoint of the trial.
Yeah.
Go back.
Can I make 2 points on this?
Yeah, just so what I wanted to make
As
was
we-
this one. So if you look at the 3:3:1 randomization and look at the primary endpoint, it was just to look at arm D versus E. So
Correct.
my point here is my comment. You all of us commenting on the Geratocilib and fulvestrant, the arm F versus the E. Was it statistical power for us to look into that, or is it that the investigators or the company were interested in looking into having a small number of patients to plan future trials? So I hope all of you are getting my point. So this was only what I feel was powered enough to just look into arm A, D, and E. This is not to answer the doublet versus the triplet story of the Geratolizumab. So this is my thinking on that. I may be wrong. Many of others are there who can speak on that.
So I think the other secondary endpoint did have the PFS as far as the blinded independent committee review was concerned, where they looked at arm F versus E as well. That was a
I
secondary
understand.
endpoint.
I was talking about the
Yeah.
primary end.
Yeah, so that was a secondary endpoint as well.
So, Dr. Sahu, the previous study, that was the study 1, had a 1:1 randomization, and they looked there. So, it's not a very straightforward study, not a very clear-cut thing where you're right. They're not looking at doublet versus triplet. My question actually is a different thing. Post CDK4 inhibitor, how much will a palbociclib add extra benefit? I don't know. So I'm not even sure why they have used a triplet. It should have been a clearer study, cleaner study with just a doublet versus a
And
doublet.
second point in this, we don't have the response rate which we saw yesterday. In this study, if you look at the response rate, although the 2-arm versus 3-arm looks similar, the response rate was significantly higher for the triplet arm compared to the doublet. So I think that it's an open question. That's my single thought, that we will listen more about it. But at this point, I don't know others if they can come in. I feel statistically the triplet looks better, and even the responses are double actually of the doublet.
So again, that's why I said, Dr. Sahu, what are we looking for? The PFS is same in both the doublet and the triplet. It's just the
Exactly.
OS that is better. Then you say that, okay, PFS is better, but the ORR is better. So, the goalposts keep shifting. That is what I have. Again, I'm not saying these are bad drugs, but I think we still don't know which are the patients these drugs work in. Because every time we use a different criteria to say something is better than the other. And I don't see a logical reason why a palbociclib addition after the CDK4 inhibitor should work. So that is something which, again, I have a feeling when you add a Ribor Abima, you're going to get better results, but that's
Exactly.
just next slide.
Vamsi, if you could probably chip in with another point as well. So I think, like you rightly said, continuing CDK4 beyond progression, we've all seen all the data as well, the maintain pace, Pamira, post-monarch, but all of that. We've all seen that whenever you change the CDK4/6 inhibitor, there's been a benefit. You continue the same CDK4/6, hasn't really seemed to make much of a dent. So I think
basically the rationale what they were postulating was that the one of the reasons after progression on CDK is PI3K, but still it's not like they're entirely resistant to the CDK pathway. So what they were trying to say, will block the PI3K pathway and it will resensitize them to the CDK inhibitors. So that is what was the idea behind combining these CDK4/6 inhibitors. Having said that, of course, 40% of the patients had already received Palbo, and we have data that Palbo beyond changing the AI to fulvestrant and continuing Palbo doesn't work. So of course, it would have been better if they would have used another CDK4/6 inhibitor.
No, I think we have to agree that the trial design is easier when we are criticizing it. It's difficult when you're making the trials. That's something we all agree.
Absolutely.
And especially when you have to have a homogeneous trial population, you have to make such changes. So that's where it is. Next slide.
Do not forget about the safety part.
Yeah. Next
the
slide.
safety of this is much better than alpelisib. So I think that's the key to using this drug.
Absolutely. Again, we have not used the drug. I don't know when we'll ever get to use the drug. I don't even know which company makes this, so I'm not sure when it'll ever come to India. But yes, it's interesting to discuss. Next slide. Next slide. Dr. Sahu, it's 8:05. Can I continue for 2 minutes?
So I think you have to conclude. Yeah.
I have to conclude. Perfect. So next slide. For me, this study, again, this is all the questions we have. Then I don't think there are right answers right away. So next slide. Ultimately, at least for this study, it is one of those studies where I would say there is a statistical significance. I'm not very sure how much is the clinical significance, and if tomorrow this drug comes, you're going to use it for everybody. Next slide. I would like to actually conclude by saying so many drugs are available for PIK3. Best drug we are still looking for. Next slide. Next slide. And next 2 slides, please. Next slide. So ultimately, last 30 minutes, no, go back. We have discussed a lot. I don't know how much of it we actually practice because these drugs are not available. Like William Shakespeare said, lot of sound and fury. I don't know what it signifies. In India, we have elacestrant, we have fulvestrant, we have CDK4 rechallenges, we have the ADCs. If you can use some one of them and pray that your patient is HR positive and a HER2 1+ or a 2+ fish negative or something like that, where you have some drug that is available in India. So I'm not going to go beyond this. I thank all my panelists and thank Dr. Sahu for giving us this chance to spend 30 minutes of our life discussing trials, discussing drugs which we may never use in our life. So over to you, Dr. Sahu.
Thank you, sir.
Compliments or that was the silence? Okay. So thank you, Vamsi. Thank you, all the panelists. Actually, this is something how science would develop. And I think all these drugs will find its own place. Some of them, although the evidence is there, like alpelisib, we would all like that drug to go away. And we would like better tolerated drugs to come in. So I'll go to the next panel. And this is to be moderated by Dr. Prabhat from TMH Mumbai. And he will be doing at least, we are looking at 3 abstracts and 2 of them in TNBC. One is the AI risk stratification. If time permits, he will do that. And his panelists are Dr. Soumya from Bhubaneswar, Akhil Varanasi, Vishwanath from Bengaluru, and Bharat again. Thanks for joining us from Hyderabad. I saw a very subdued Bharat Vaswani yesterday. Hope he becomes aggressive today. Prabhat, it's all yours. Prabhat is there? Support team?
I am there, sir.
Yeah, Prabhat, please share your slides, please, Prabhat.
I was hearing
So Prabhat,
Dr. Vamshi.
840 is where we'll stop. Yeah.
Yes, sir. I was hearing to Dr. Vamshi. He concluded saying that we may not be able to use the drugs that he presented. That was my opening dialogue, and now I can say that his drugs are tablets, and so generic can come easily. My drugs are antibody drug conjugates. Definitely, maybe we may not use in our day-to-day life, but till I retire, maybe. So let's start the panel discussion. It's TNBC. The AI generated slide itself says now in TNBC you only have to talk about ADCs and nothing else in future maybe. So first line, it used to be chemotherapy. All my panelists are there, sir.
Yes.
So chemotherapy era we thought most of our patients have a modest survival of 12 to 18 months. Then came the era of immunotherapy, and we do check PDL1, and then Chinese immunotherapy have eased our pain slightly, and we do check PDL1 for most of our patients now. And PARP inhibitors have for a wonder drug for BRCA, at least oral tablets can ease their life. Then now in 2026, first line and second line that we are going to discuss, both seem to be ADCs and may not be easily feasible for us. But the 2 years, patients have started reaching 2 year survival mark. So let's come to case scenario 1. A 52 years old postmenopausal female came with complaints of left breast lumps in 1 month. On evaluation, the biopsy showed that it is a triple negative breast cancer, and a PET scan done revealed by there are bilobar liver metastasis. So, open to my panelist, what else evaluation do you do presently in your day-to-day clinic?
So probably, sir, the most important thing in TNBC in a metastatic is PDL1 by CPS score and a germline BRCA mutation. That is what we commonly do in a TNBC, which is also a part of all the guidelines present.
And
we are doing PAL B2 also. We do HRR gene testing. So I do both.
So to add to that, we will do also look at the HER2 new, so that we should not missing out the HER2 low part.
But
exactly.
TNBC already mentioned, yeah.
And at what level of PDL1 do you act?
Sir, more than 10% in a first line setting, CPS of more than 10, we add on a IO, that is pembrolizumab, sir.
And the Chinese IO?
So I have not used and probably with a.
I think based on,
yes, sir. Vishwanath, sir.
Yeah, based on the Torchlight trial, I think I would also be tempted to add toripalimab with nab-paclitaxel if it's more than 1%.
Excellent. So that is why I went into dissecting the data. So even in CPS of 10 to 20, for pembrolizumab also the confidence interval is crossing 1. So I have my doubts whether really 10 should be our cutoff, and more than 20 I am more say. This is my personal US FDA or other agencies have approved for more than 1 also. But maybe 10 is also not the appropriate cutoff according to me. Between 10 to 20 somewhere is the cutoff where confidence interval will be less than 1. This is what I'm talking from the pembrolizumab study, that even for 10 to 20, the confidence interval is more than 1. Anybody has used any of the drug ADCs that we are going to talk about and has checked top? Do you decide based on the top 2 levels or based on the affordability status, or in second, third, fourth, fifth, seventh line when patient relatives suddenly from US start and says, "अरे तुमने 10 में कोई टिकट दिया नहीं अभी तक?"
Sir, we don't decide our secukinumab dovitaken based on TROP2 level. Saying this, maybe at high TROP level, we tell you that the response might be better, or maybe you might, but otherwise the drug selection is not based on TROP2 level. But if you have TROP3 and TROP4, so IHC staining more than 70-75%, probably the quantum of benefit may be more. But it should not deter you even in the lesser TROP1 or TROP2, the lesser part, you should give this drug, sir.
Yeah. So trastuzumab taught us that antibodies work when there is high level of the receptors, but now maybe ADCs don't require the receptor to be more than certain quantities, and they work irrespective of the amount of levels in the body. So till 2026, I think all my panelists agree with the flowchart. There we used to check for PDL1 more than 10, as everybody said. Germline mutation. Anybody acts on the somatic mutation? Does anybody do somatic BRCA mutation?
Sir, Amish sir put a comment, HRR. So we have HRR contains both somatic as well as germline, because we are doing on a tumor tissue. So sir, any sort of a mutation, although that Olympiad had germline, but if there is somatic, I think it is, we know from the data from ovary and other cancers that this drug should work even in somatic. Some quantum of benefit may be less, but yes, sir, if any of that BRCA or PAL-B2 is there, I think so we should give olaparib maybe in the first line in those with a CPS of less than 10.
Right now, I'm not doing that, so I'm sticking to the germline BRCA only.
Okay. Anybody else? Dr. Vishwanath or Dr.
Yeah,
Akhil?
me too. I'm just doing germline BRCA in the first line.
So no NGS business in TNBC?
Probably beyond first line.
We do, sir. We do, as a matter of fact.
On progression only.
On progression. So I also do it on progression as initially somatic NGS, somatic BRCA mutated, I may not act as first line with olaparib. And now that PDL1 negative, even TROP2 ADCs are there. But both the TROP2 ADCs are slightly different, as we have seen that those who have a hydrolyzer linker, they lead to releasing the conjugate the outside the cell, and that is why they have higher toxicities, and that is why SG is used very selectively. But I feel it is a toxic drug and almost similar to chemotherapy, the side effects profile. Dato TDXT I have never used, and it is exatecan based topi eliminase, which is the cytotoxic payload, and it does not have an hydrolyzable cleaver. So maybe side effects are less. Once we have hands-on on both the drugs, we will know which one is better. Before moving to our subgroup analysis topic given to me, I have just went through the original article of SN04. Anybody has comment on the trial design here? I have another slide. Oh, no. So for SN04, I don't have that slide. Anybody has any criticism that trial design was wrong or the comparator arm did not have all the drugs option available that we use day in, day out?
Sir, not really according to me, because if you see the drugs that were giving subsequently, so 80% of them really took secukinumab. So probably crossover, they although not part of it, but they were allowed second. So 80% of patients really took it in the second line in those with a chemotherapy arm. So, sir, that was it. More than 10, we have IO. Now what on to and so secukinumab basically, if you see the PFS 11.2, none of the trials has reached that 11 months golden mark of PFS. So definitely there was an addictive effect there. But at the end, OS, when we see the final analysis should come whether giving earlier, probably will help. If there is a OS advantage, I think this is the way to go, sir.
I totally agree. They were very generous. Yes, Vishwanath sir.
I think I also agree with that. I think if you look at the PFS benefit, it's kind of unprecedented. It's 11.2 months, which is fantastic. So it just goes to say that this combo of ADC with Pembro is good. But like Dr. Bharat said, there's a crossover. 80% received SGE on progression, and that's the reason for the PFS1 as well as the PFS2 benefit on progression.
Yeah. In fact, with so much crossover, we don't expect OS to come beneficial also. So it's fine. Even if OS doesn't come positive, getting a good OS, good PFS is fine enough actually. It is too much demanding. You are asking for 80% crossover and then asking for OS also actually. This is what I think from the researcher point of view, because we design a trial, we think in that way that how to get it. Yeah.
I just want to make one more point that if you look at the OS, though it is immature for all these trials, for the Torchlight trial, it's actually 32 months.
Well, that's small.
Agreed. Which is unprecedented. Even with ADC, it is coming at 23 months, but for them, it is 32 already. So I have my reasons to criticize Torchlight.
See, about the Torchlight and others, I've spoken that they have an estimated survival. Most of these patients have not crossed 9 months. Look at that Forest Kaplan-Meier and patient at risk. After 9 months, there is only 10 to 15% patient actually on patient at risk. So basically, it's a very early results.
Most of the Chinese data. Yes, sir.
Yeah, that's what
most of the Chinese data, the follow-ups are very short. They are always definitely in a hurry to present. It is fine. But yes, this is definitely a point which I agree with.
Just to add some more noise and fury, like Dr.
So based on limited experience.
So Amit just commented about the control arm being inferior. Control arm was Pembro plus chemo, na?
Control arm is Pembro plus chemo.
No. Tarini.
Yeah.
What I'm saying is that in the Pembro plus chemo versus chemo, the original article where the Pembro was approved, the Pembro plus CT at 9.4 or 9.5 months. Okay. And here the control arm of Pembro plus CT 7.5 months. What I'm saying is the modest gain in SN4 of 3.5 months is also because the control arm performed inferior compared to the landmark trial. That's what I wanted to comment on the chat box.
Sir, Probably it is always good to give all your active agents in early part of treatment. That is the thing, because if you see the patient who subsequently went to second line, only 60% were able to take the second line. So why to deny your patient a good drug in earlier part of treatment? Absolutely, because these two drugs are probably the most new, potent, and the better drug with chemo. So probably giving earlier, you might give every patient of yours that benefit of this, because there are around 30 to 40% who will never go for the second line. That is the only thing.
But Bharat, if we have to see now, yesterday also we discussed. Prabhat, sorry, cut me if your time is running out.
No, sir.
You have,
I'm
you
looking at
as
the
a
time.
moderator, you have all the luxury to do that. So Bharat, with yesterday only we were discussing with Keynote 522. Now they have shown the mature overall survival data. Many of these patients who are progressing after neoadjuvant or adjuvant will receive PD-1, PD-L1 inhibitors. And in this SN04, only 9 to 10% of patients received earlier PD-1. So this is also going to be a challenge for us to decide if the patient has received in the neoadjuvant adjuvant setting, and then the patient progresses at 1 year or earlier, what are we
So then
going to
patient
do?
is eligible
Sir,
for
I think,
SN03, sir.
Sir, Dr. Amish, sir, Dr. Vishwanath here. I think this is where probably, the Tropion Breast 02 study, the datopotamab also will come into play.
Within 6 months.
Absolutely.
But if you
Within
see
6
the
months
PFS
of
benefit, it's
So we'll
10.8
come
months
to
there.
both of them. But my point here would have been that SG, because of the hydrolyzable linker, has good amount of toxicity compared to what chemotherapy is giving. Almost equal number of grade 3 4 toxicities you see with SG compared to what chemo is giving. But yes, undeniably that PFS is really superb. Everybody has discussed, and median in the control arm can be lower because carboplatin was not there with paclitaxel here. In keynote, it was paclicarbo.
Yeah.
Maybe. And then coming on to our topic today is the subgroup analysis, where they checked for what my panelists also said that they would check for BRCA status and HER2 status, accordingly decide which drug to be given. So in subgroup analysis, they even checked TROP2 on a score H score, which is there even for ERPR, but we don't commonly use, where this the scoring is from out of 100, out of 300. Sorry, and BRCA status and HER2 status, because for HER2 we know TDXD is there, which is easily tolerable. In subgroup analysis, as I said in my debriefing, that trastuzumab taught us to check HER2 status, and TDXD is making us forget the HER2 status. Same is true for this ADCs also. TROP2 levels did not predict the quantum bomb benefit in except for quarter one, where there's 0 to quartile 1, where the amount of PFS benefit was not that great. Otherwise, for quartile 2, 3, and 4, more the expression, more the benefit. But for 2, 3, and 4, the expression seems to be there, except for low TROP2 level. So, will my panelist, if SG is available tomorrow and in feasible rate, check TROP2 level, or irrespective of TROP2 level, will we give, considering that PFS benefit is modest in quartile 1 and toxicity is similar to what chemo would give?
So it is irrespective of the drop to level. So
Right.
drop is a very kind of a good marker. So initially the AstraZeneca was also confused with whether to do a drop to IHC or then shift to the QCS. So they made a QCS later on, and all the drop to IHC was done prior to that. And the QCS is based on the NMR ratio or the membrane. So TROP2 is a membrane receptor basically, and they want to see that whether the membrane, the TROP2 is still intact or it is in the cytoplasmic. So theoretically, if it is there on the membrane, the SG should be acting. But unfortunately, the QCS also is not a very perfect biomarker. And again, TROP2 is again still very imperfect. SN4, there was some positivity. Again, SN3 was not a positive one if you look at the quarters. So basically, TROP2 is not a perfect marker. So I mean, at least from my side, I am not convinced from the TROP2.
Yeah. At this moment, we should give it irrespective of TROP2. That should be the take home.
Now, I have a question here, Prabhat, if you allow.
Yes, sir.
Were these powered Q1 to Q4? Were these
No.
powered to show the differences?
No.
Because
sir.
in Q1, the hazard ratio, what you have shown is 0.81, and
Yes.
Q3, it is 0.46. And the separation of curve is also right from the word go in Q3 and Q4. I'm
Yes,
just
that is
seeing
why I said
the
Q2,
report.
2, 3, 4. I am happy looking at the difference, and definitely the amount of receptor is making some difference. We are reaching PFS of 16.6 here compared to only 9
And this
and
Q1
9.3.
to Q4 had PDL1 also incorporated.
Yeah, PDL1 was given to everybody. Pembro was
No,
given to
no.
everybody.
What I mean to say, Q3 plus PDL1 more than 50%, Q4 plus PDL1 more
No,
than
no.
20%.
No, sir.
Not like that.
PDL1 was more than 10. That's it.
10% in all the way.
So they do not have any other data.
No,
Okay, okay. Otherwise, it would have been interesting.
because SN, this is SN4, SN3 is totally different. They all stick to each other. So the drug is same as
Yes.
the, but they stick to each other.
Yes. And that is why I enjoyed reading back to back both of them.
Yeah, this is not
Uh,
not powered for that.
Another good point I felt was the BRCA status. Because it is top one isomerase inhibitor, a top one inhibitor is the payload. You can see in mutated patient there is good amount of PFS benefit compared to non-mutated. It is significant in both. I'm not doubting that, but because of top one as a payload, there is good. The difference is improving more in the patients who are germline BRCA mutated. So the olaparib is definitely an old drug, but yes, this drug is also hyperactive in patients who with germline BRCA, tumor BRCA mutation status. This is tumor BRCA, not germline BRCA. So what would my panelists will start testing tumor BRCA status and then prefer, or will give it to everybody for BRCA?
Again, sir, this trial tells us that it works in both. If you see the hazard ratio and while it is 0.91 higher limit, here it is crossing unity 1.74. You should give it irrespective of your tissue BRCA. It just gives you a good option of olaparib subsequently. But I think the take-home message should be you should give it irrespective of whether it is positive or negative.
Correct.
Good, sir. Thank you. I just pointed out the
Status.
PFS benefit. Good for pointing out the hazard ratio. I deliberately did the PFS benefit only.
Yeah. This is
Yeah.
too much torturing of the subgroup analysis actually. So it doesn't
Agreed. That is why,
yeah.
Mr. Question is relevant. Was it powered beforehand? So it was not. And they till they get the stage presentation is what I was thinking. Why was this abstract as stage presentation? It is just the subgroup analysis of the originally published data. Uh, because today morning in TMH we had all 12 presentations from our hospital back to back on our Thursday morning rent round, where people had so much difficulty to get into stage or poster presentation. And then I was making PPT for this, and I was like, they get stage presentation just for a subgroup analysis also, and we get poster for such things. So coming on to next, ineligible patients where PDL1 is either negative or patients cannot take immunotherapy directed drugs. So first such scenario, we come on to the next trial that is SN03, where patients were the original article, and I have given back to back as someone was remembering Tropion Breast 02 design. Both the designs according to me are almost the same, except for the fact that they allowed a carboplatin also. The Ascent were more generous people with gemcitabine carboplatin was allowed, and Tropion 02 have allowed only single agent chemotherapy drugs in the comparator arm. But yes, TDXD is given only once in 3 weeks, so that seems to be better for me. Comparing cross trial comparison, I'm not doing. I'm just saying ease of administration of this drug, and PFS benefit roughly seems to be the same in both. The magnitude of benefit roughly seems to be the same. What my panelists will given a choice that both have been done in similar populations, which would be their favorite drug?
So I think if you look at the Tropion Breast 02, I think the data is more mature. So I think there is OS advantage also. I think it's around 23 months, 23 or 24 months.
23.7.
Yeah. 23.7 months, I think. So here you have a PFS2 benefit. So the OS is not mature. So it's
PFS2.
I think datapotamab has got little better data.
Sir, now we have a PFS2 data also in this ESCO where this SN3, there was two presentations. So soft parameter, ease of administration is better with DOTA 3 weekly versus day 1, day 8. Some response rates are different, maybe due to that. So 63% response rate with dotapotamab. This secukinumab was around 50%. Then again, when you see the toxicity profile, sir was discussing Prabhat again and again, toxicity profile is different in dotapotamab. Probably lesser grade 3 toxicity, 70-75% in secukinumab versus around 30% here in this DOTA trial. Again, a bit safer, but you have some different toxicities like ocular toxicity and stomatitis. So probably both are equal, but the patient profile should tell us what is the best drug. So contraindication, I think so. Like we always used to say about CDK4/6, how to choose before when we started the debate. Probably the toxicity profile and availability, ease of administration, lot of things to tell. But efficacy wise, I think both are more or less equal, sir, because both are TROP2 against, both are topoisomerase 1 inhibitor basically. Toxicity probably is more for trastuzumab and twice a week. That is something which is against that point, and a slightly lesser response rate, what I could understand.
So one more, two more points. One is that probably in brain mets, the dato DXT might be working based on the Tuxedo 02. There is some means preliminary data. It is not fully yet over. The brain mets part. Second is that patients who were relapsing within 6 months of exposure of
6 months.
So they were also more in the dato DXT. I think these 2 points makes a difference.
Dr. Prabhat, one more point I wanted to make. I mean, just to add to the mix, the ISA-BREN trial, you see the hazard ratio of the the PFS hazard ratio
0.28.
9. So just adding
We
to
will come to it,
the
sir.
second line.
Yes. So again, subgroup analysis they have done, and for TROP2, this time for TROP2, as already pointed by Soumya Panda, that it did not make a difference. Even patient with quartile 1 of TROP2 had good PFS benefit compared to patients and almost equal to patients of quartile 2 or quartile 3. So here, in fact, if we go to the hazard ratio, it is 0.54 in quartile 1 itself. So maybe, as he was pointing out, that the IHC marker for TROP2 is not that robust, and so we need more robust marker. If at all, that would let us know which patient to choose for a TROP2 antibody, or maybe all comers are eligible for TROP2 antibodies. Same
8
in this.
minutes more.
Yes, sir. So moving on to our third abstract, neither did again BRCA or HER2 status decide the outcome. So all patients can receive, all TNBCs can receive either SG with or without pembrolizumab based on PDL1 is my takeaway. I hope my panelists agree with it, based on all the subgroup that we saw in both the trials.
Is used. Amish spoke about pembro, the neoadjuvant, and even the adjuvant. What actually are you going to reuse after a particular time gap, or is the drug out of your?
So, sir, more than
Maybe
12
after
months
1 year.
PDL1, I think in that trial, to re-challenge PDL1, more than 12 months was required.
More
For
than
previous
12 months
patients.
was required.
Yes.
So
So
anything
Advait, I
more than
think
12 we reuse.
that's what the answer is. More than 1 year, the panel thinks that they can use it. Please go forward. Yeah.
So, one thing is that when the patient is a BRCA positive, then probably we'll use the BRCA inhibitor earlier than later. So that's what means from my side. So we cannot delay the BRCA to later line, because we know that the BRCA is kind of a resistance. Once the resistance clones develop, then it will hardly act. And again, platinum, we don't have a direct trial like Olympiad. So these are all mixed kind of populations. So we cannot tell that patients who are not exposed to gem carbo or say carboplatin in that, for that matter. So to delay a BRCA, somebody who is PDL1 means negative. So we have to use it either in the first line or in the second line. So somebody with a very kind of indolent indolent kind of behavior, probably we'll have to expose them early. And somebody who is very kind of aggressive than gem carbo, and then followed by maintenance BRCA. So cannot delay the BRCA part for later lines.
They work best in the first line only.
I agree with Dr. Soumya that it is a directed therapy for such patients and an ease of administration, as was pointed out by Bharat sir in SG case also. Oral BRCA is really very great ease of administration for patients. And we know it is a targeted therapy. So better to give BRCA a directed olaparib first rather than keeping it second line. So now moving on to the most like abstract of today is the drug bispecifics have come to solid tumors also. So bispecific ISA-BREN, don't ask me the full form, is targeting anti-EGFR and it is targeting anti-EGFR and HER3. And on top of that, it has a payload also, which is nothing but topoisomerase inhibitor, top2 inhibitor. And this was a clean design and a Chinese drug from China. All the centers were from China. And they also started copying of dual primary endpoint and splitting the transferring the alpha. if the PFS was significant. And secondary endpoint was overall response rate PFS, something which I would expect. I wouldn't want to criticize trial compared after looking at the outcome. Anybody wants any criticism on the trial design? It seems to be clean trial design. A standard arm in second line, third line, standard arm, only thing gem can be added, carbo could be added. Or any other
Third
solution
line,
or
it was a third line. Probably all might have used by now.
by now.
So
Everybody agrees?
No, in the design of the trial, if we see there is no mention that the patient has already received a IO or ADC. I think that part makes a difference. They only mentioned taxane, so it is kind of a very old kind of a design. So most of the patients, the data has to be there. How many have received a IO or a ADC at least?
Correct, it is there.
Dr. Prabhat, if I'm not mistaken, 30% received IO.
Yeah, that is written, sir. It is written. 30% received.
IO is there, ADC is
Yes.
not.
ADC is not there, IO is there. But I feel ADC will still not be standard of care in China, and that is why most patients wouldn't have received. So real world, what will happen after ADC with this bispecific ADC? What will happen is anybody's guess. Is what I think. With subgroups, they have said PDL1 prior PDL1 is there in 24% of patients in both the arm, and neoadjuvant therapy was also there in 80% of the patients. So most of the patients were relapsed, and only 20% were de novo stage 4 disease. And HER2 status, even they have tested. Maybe now HER2 is standard of care after the outcome of TDXD trial. And very nice hazard ratio of 0.3. Already somebody had pointed out that Isabrin really hazard ratio is 0.3 with significant p-value with PFS more than doubling from 3.1 months to 8.5 months. And seems to be relatively safe and in working in all subgroups. And relative OS also benefit in second, third line. Now we saw in first line 11 months PFS, and in second, third line they are showing PFS of 15.9 months. So maybe 32 in Todd's Go is because of adding second, third line with this bispecific antibody drug. Response rate is obviously more compared to what conventional chemotherapy would give. I am impressed with trial design, so I am not having any discussion. Any of my panelists would like to add anything?
Sir, we are discussing a drug in second and third line whose PFS matches first line drug. So nobody can imagine. We were discussing about sacituzumab, this CD10, the PFS is 8.3 months in a second and third line, which is comparable to drug in the first line. So probably you will see this drug more earlier, and probably this might become a treatment of choice in future because separation.
One slide back, please. One slide back. That forest plot. Yeah, yes, thank you. Please continue. Please continue.
Yeah. So, sir, the PFS 8.3 months in the second and third line is unprecedented. In first line, if you see anybody reaching there is a big mark, and these are all 70% had already taken one line, and 2 lines were there 30%. So probably for me the most impressive data in this ASCO in breast is this drug only, and probably this will be a game changer for those because now we have a very good potent drug post ADC. We have probably this will be the drug we use sacituzumab or dotepotamab with immuno. What next? So probably this will be a drug to go once it is available. Too good data. The PFS is thrice the control arm. The moment you reach, and if you see the OS also after third line, I don't think so many of us will really be able to take any chemo. So probably one of the most better drug, 50% response with a 65% disease stabilization in the second and third line is as good as the de novo fresh cases. So all good things in this data. If you show the disease discontinuation is less than 2%. So I don't think any of the drugs we have. So that will be the most impressive. One of the most safest drugs here.
One of the safest drugs. Agreed.
Probably the only
discontinuation is only 1.9%.
Probably the only caveat, just to echo what Dr. Soumya mentioned, is probably we don't know whether ADC was given previously.
Yeah,
theoretically, that means it's a different mechanism of action. Payloads are still both are having a topoisomerase 1 inhibitor, but theoretically this one target is different. This one is HER3 and EGFR, and these are TROP2. So if you give a TROP2, probably SG, and then there might be a TROP2 loss. but EGFR and ISC, this HER3 might still be retained. So it might still work theoretically, but we don't have a data to tell that.
And it is a Chinese drug, but
but
if you see, BMS has taken over
no,
this
but
drug.
TDXD doesn't work after SG. So ADCs,
Last
in
minute,
spite of
I
having
think these are
Prabhat,
different drugs.
last minute.
targets.
TDXD is drug antibody conjugate. This is a bispecific. It is an entirely
No,
different drug
agreed.
at all.
I'm just pointing out that even if the target is different, the ADC after ADC doesn't work. So what will happen that I don't know, but I'm impressed with this at present. And discontinuation, only thing is less number of patients could go on to next line of therapy in the experimental arm. So that was the only thing disappointing. The toxicities are morely hematological and rather than any other organ toxicity. So well tolerated drug, and maybe this will become, according to AI and according for India, maybe after 5-7 years, that first line will still be SG with or without Pembro based on the CPS, and later on it would be bispecific ADCs. So this I will discuss in very short, where
Just can
the
you
team.
conclude yourself this part of it? Yeah.
Ah, so they tried to see whether AI pathological model, they trained it using on the CalGB data and on the Taylor X, 60% of the patients of Taylor X data, and on remaining 40% of Taylor X data and Chicago 2004 1086 patients. They validated, and they what they have found that in patients with node positive, they trained it whether what is the chances of recurrence, and their AI pathology could predict late recurrence more better than what our Taylor X does. So may I AI path did more better prediction compared to what Oncotype DX could predict, and early recurrence less than 5 years was almost the same in both the arms. So they later on integrated all three, and they are trying to sell now Path Clinical RS will outperform each one of them, Oncotype DX, AI Path, and tumor size, and would be better. So maybe more and more data, if you feed to somebody, you will be more wiser and could find out which are the patients who are at high risk of recurrence in early node negative hormone positive disease, is what they are trying to say. But will
So
are
only
we
thing I have to
confident?
ask you, Prabhat, will this be cheaper?
Yes, sir. So
It's
that
a
I
computer
thought
based at the end of the day.
it is computer based. उसका hack कोई तो निकाल लेगा. That is my thought process. इसका hack निकालना would be very easy compared to what Oncotype DX का original वो निकालना. That is why we are still not able to crack Oncotype DX. But ये तो software है. अपना कोई hacker अच्छा Chinese hacker या Russian hacker can hack this and find out. While preparing
Thank you.
slide, even I was thinking this. Thank you, sir.
So can you come to your conclusion slides, maybe? Yeah, it's
That's it,
done.
bro. Yeah.
Okay, so I can ask Akhil, because he has spoken the least in this panel. One quick, Akhil, your last thoughts on the bispecific. Do you think it is the approved and will be the go-to second line after we have failed that IO, and we can then use a ADC in the third line?
So definitely, ADCs, specifically bispecifics. I think the case the which you highlighted, sir, Dr. Advait's question. Those are the areas where we know the outcomes are going to be very, very bad, especially when the patient has visceral crisis, patient has progressed on one of the ADC, one patient has received immunotherapy. We have very less to offer. So definitely, this data is actually very good. If it can be actually replicated in the real world scenario, something like that, that will make it really, really useful. And bispecific seem to be the way to go. The area where we know the outcomes are really poor, PFS of 3 to 4 months, we are getting a very good PFS of 8 to 10 months. So that is impressive.
So thank you, panel two. And now we move to the last panel before we go to the best, actually the top three picks of Atul Batra. So we will have KP, and his panelists are probably one of them, one or two are not very happy. Prasad is grim, very angry, and you see his anger showing on his face. So Prasad, so KP is a dear friend. We'll be taking the rest of it. That's a miscellaneous, and he will have 2 or 3 abstracts to go through. And his panelists are Prasad from Bangalore, as I spoke, Ghanshyambai from Bhubaneswar, Nilesh from Mumbai. Akhil stays on, and we will have Tabassum, our radiation oncologist, and who is in Tata, Mumbai, to be there to complete the panel. Please, you will have 30 minutes. So 9:50.
Yeah, can I have the slides, please? Can I share the slides?
Please,
I
can
will share
someone
it. I will
share the
share it.
slides for him?
No, I'll share it. Just allow me
So
to
you
share.
want to share? So
Yeah.
please take away this slide.
Yeah. Daud, remove the slide, please. Yeah.
Now
So in the meanwhile, I'm happy that we have a radiation oncologist in the panel. Uh, I think it'll be nice to get a different perspective.
Tarun, please,
So
can you take care of the slide? Yeah, please, happy. I
yeah.
like your sofa, by the way. You are in the most relaxed position, actually.
Yeah. Okay. So
Please
I
go ahead.
hope the slides are seen.
The names are seen.
Is the slide is visible now?
No, sir. No, sir. You can see the Zoom speaker attendee view.
It was also not visible till 7:30. So
ऐसा मैं
try
कर्मा
again.
लेट शेयर किया देखो ऐसे ही होता है
केपी कौन से रिसोर्ट से कर रहे
Share
हो
entire screen. Okay.
भाई इसका घर रिजॉर्ट है भाई तुम क्या सोच के रखे हो नहीं हो
Is
रहा
it
फिर से
seen
नहीं
now?
हुआ नो स्टॉप शेयर फिर से
Okay.
have you sent it to
I
them
have sent
yeah
it.
now it's there
I think
now it's coming slowly
Is there.
just went
share.
away no
Oh, okay. Share entire screen. Is it visible now?
no
Background
yet.
में
To
खत्म
minimize
दिख रहा
Zoom
है
and
but
then open up, it'll open, yeah.
Yeah, now it's there.
now it is visible.
Okay,
Yeah.
thank you. Sorry for that little bit difficult thing. I thought the topic was difficult, but now I realize something else is more difficult. So we have three topics, and anbenitamab, which is a structural evolution of HER2-positive oncology. So if you look at the 2025 most exciting drugs which have not yet been approved, enbenitamab is there, one of them. So that is the first interesting things. And the one Bharat was very excited about is in actually number 10. So apparently this is more exciting. So where is it actually approved? It's actually approved in China, and it is approved in gastric cancer. In HER2 positive gastric cancer, you can see that the response rate is around 40 to 45%, and the disease control rate is 80%. This is in refractory patients who have already failed first line standard therapy with trastuzumab plus chemo. And now it is actually a granted orphan drug designation, and probably this will come here in the near future. So, Gansham, if you can just let us know what is this
So
Gansham, are you there?
yeah. So we have been using trastuzumab and pertuzumab. So we know that trastuzumab has a different binding site and pertuzumab has a different binding site, and that's why we get a synergistic effect. So we have seen that with trastuzumab, pertuzumab. We have seen with the DV09 also, and so TDXD and the pertuzumab story. So I think so now this drug, it is a time for bispecific, and this drug actually is targeting both those domains, and thereby one drug is there.
Prasad, your thoughts on this drug? Why do you think it is better that 1+1 is better than 2?
So on a lighter note, this drug's name is easy for me to remember as a South Indian. The Anbe means deer. Nita is my wife and then map. So after a long time, when I saw this presentation of yours, this name struck actually. So if it is exciting, I have to remember this. Otherwise, I don't get my dinner. And from the point of view of science, I think it's always interesting to get new drugs. And I just read in the morning that there are 500 and more than 500 new ADCs which are ready and bispecific from China. So this is another one of them. And we are going to use them as and when we get it, actually.
Yeah, Akhil, can you just elaborate why is this probably better than using trastuzumab and pertuzumab?
Basically, actually, what I could understand, they have devised a mechanism by which the drug can lead to forced heterodimerization of the receptors. So that will lead to downregulation of both receptors very fast and will lead to very strong activity. Otherwise, what happens? The heterodimerization is not forced by either TRAS2 or PER2 alone. Here, both are being given, both have, there is activity of both. At the same time, there is a strong heterodimerization, forced heterodimerization due to its something called crib mechanism.
Yeah, I think the crib mechanism is how this drug has been developed and how it actually works better. That is, 1 plus 1 is better than 2, is because when you give trastuzumab and pertuzumab as two different agents, there is disconnected engagement. Whereas when you, this is a biparatropic binding. So it binds together both the domains which were supposed to be attached with trastuzumab and pertuzumab. This results in spatial clustering. All the receptors come together and then rapid endocytosis occurs. Then there is degradation and hence there is a profound receptor downregulation. So probably this is much better than giving trastuzumab and pertuzumab separately. And in first line breast cancer, there has been some phase 2 data. And if you look at it, the KN026, that is this drug plus docetaxel, it achieved a median progression-free survival of 27.5 months. Compare it with the classical Cleopatra regimen, which achieved 18.5 months. So hence, at the present moment, as we speak, phase 3 trial is going on where they combined this drug along with HB1801, which is nothing but, albumin-bound docetaxel versus trastuzumab, pertuzumab plus docetaxel. So this is ongoing. But why I think Sahu selected this, particular drug is because in ASCO 2026 from China, they presented this 520 patient data, called the Neo-Healer trial, where they use this drug along with docetaxel and carboplatin, plus minus, not everybody received carboplatin, and compared it with the classical TCHP. And Nilesh, if you can tell us what it showed.
So basically, what was very striking and reflecting the biology of the use of the drug was that it had a significant improvement in the PATH-CR from 51% to almost 62%, with a delta of almost 11.2%. So pretty impressive results with the use of this combination along with chemotherapy.
Akhil, your thoughts on this particular study which was presented, the Neo-Healer?
Yeah, so getting the further increase in PATH-CRs are actually difficult in HER2 positive space. There was a time where we were actually stuck to improve the PATH-CRs. We were devising trying to de-escalate treatment, but here how somehow this double engaging activity at the same time, as we know, there have been drugs like ivonescimab, again, a drug which is bispecific. So bispecifics have somewhat better response rates and higher chances. So somewhat we are seeing the similar part here as well. Increase in PATH-CR rates at least, and definitely it is expected to have long-term improvement in the outcomes. That data remains awaited.
Can I just make a comment?
Yeah.
Sorry, this improvement is almost in the tune of where we have DB11. The neoadjuvant TDXD
Same
followed
delta,
by
actually the same delta.
Same delta exactly, and almost 63-62%.
But only HR negative had almost 88% plus. So that was much more than the HR positive disease.
So in this trial, interestingly, carboplatin was optional. So Ghanshyam, in your practice now, is carboplatin optional even in the neoadjuvant setting?
Yeah, so after the last ASCO the trial, so because lots of hematological toxicities, and that too in the first cycle. So when HER2 loading dose, pertuzumab loading dose, so diarrhea and hematological toxicity are enough. So now for quite a lot of patients. So I'm just stopping platinum. So though I start with the first cycle and maybe a second cycle, so subsequently, if the patients require transfusion, the neutropenias, no, so yeah, stopping the drugs.
So basically, your trigger for stopping it is very low now. You would stop in case of any
Right.
minor.
So we are not being wrong. So in a curative intent, so that in the hindsight, so you are not wrong.
Now we have a
Prasad, what
series
about
of
you?
trials, actually.
Pardon?
Now we have a series of trials from Helen 6. Now Neocar SP full publication is already out. Neocar SP published just 4 days back in JCO. There is a very nice editorial to it, actually. So rise and fall of carboplatin. So definitely that is a very nice to read. So I request all to read that. That will give a very good.
It is good that when the platinums are scared, so
Yeah.
there is.
So Akhil, what is your practice now? You are using carboplatin or not?
So definitely not in stage 2. In stage 3 with the high nodal burden, we still use platinum. But as we discussed, we will be happy to drop it if the patient is developing significant toxicities.
Fine enough. So I think the next evolution seems to be the same biparatropic ADC.
KP,
Basically, the
one
same
comment on
drug.
this
Yes, Prasad.
the chemotherapy actually is a NAB docetaxel.
Yes.
That is also
Yes.
something interesting, right? After these
Yes.
many years of docetaxel, some new that also could have made a difference in the outcome, right?
You are right. You are right. If you see, they did not use that docetaxel in the comparator arm. They used the standard docetaxel. So definitely, it is something interesting. So actually, they have gone to the next level. The same, monoclonal antibody, they have added a topoisomerase, a payload, and now they look at it for refractory diseases. So probably now they are looking at this paratropic monoclonal antibody in virtually all settings, from first line metastatic to later lines and even in the neoadjuvant. So probably, this seems to be the way to go, because it seems to give you as good benefit as more toxic drugs are giving. So what if it is available tomorrow, Prasad? Where would you place this?
I may not replace the present practice, no, that's for sure. And that also depends upon at what cost the drug is available. Because I think if it had come before the biosimilar pertuzumab, then there would have been something of interest. I'm not saying I will not use the drug, but it is not as exciting as it would have been otherwise. And so definitely just by PATCR, I would not change a neoadjuvant treatment plan.
Oh, okay. Gansham, what about you? It's available tomorrow at the same price as generic trastuzumab, pertuzumab.
So I rather use a DB11 for this situation, at least which have more mature data than this. So we'll have to wait for event-free survival and also no, so only with this PATCR treatment not.
Definitely, we need to wait more for more results.
Yeah.
Initial PATCR rates are not the only answer. So I think that makes sense.
Fair enough. So I think at the present moment, you would wait for more data. So this was touched upon in the previous discussion. Now that we have got at least 3 ADCs, at least 2 of them easily available, however expensive they are.
KP, can
Yeah.
we go to the Optima first and then come back to this program?
Oh, okay, fine. So
So we can go to the RT thing and then come back to this. Is that okay?
Okay, fine. Yeah, that's okay, fine. Because that I thought I'll do that in 5 minutes and then concentrate on the last one.
Yeah, you
We
can
can do
consider the
that.
RT thing and then come back.
Yeah. Fair enough. So this is the oligoma trial. Basically, it is a metastatic directed treatment in patients with oligometastatic breast cancer. This was presented in ESTRO 2026. Madam, I think we need to get your thoughts on this trial and the strengths and weaknesses of this trial.
Yeah. So, if this is the trial that has come positive, compared to the NRG BR002 and the extent trial that were done specifically in breast cancer oligometastatic disease. The trial that had given way for changing practice was the SABR Comet, but that trial was a basket trial, and only 18% patients were breast cancer that contributed to that trial. Coming to this trial, this is also, we have to say that though this is a positive trial, there are certain points which we should keep in mind. First of all, this is a trial which was powered for around 500 patients, but they could not complete the accrual because patients demanded ablative therapy out of the trial, and also because what they presented was, they said that because of the changing systemic therapy, they could see that this trial is not possible to complete the accrual. So we are now talking about patients who have less number of patients that have been randomized, and they had initially projected progression-free survival of around 12 months in the standard arm. However, the actual progression-free survival was 19 months and that was what the expected progression-free survival in the test arm. But their standard arm was also performed well, and the progression-free survival was much better than what they had anticipated. So though this is a positive trial, there are certain differences from the earlier trials. First of all, in this trial, they had included 50% of patients that were having synchronous oligometastasis, compared to BR002, wherein they had accrued the patient only if the patient has not progressed for 1 year. So it was a pretty selected cohort in BR002, where extremely favorable patients were taken, those who remained controlled for 12 months, and then they had accrued. But in this trial, 50% was synchronous. And the other difference is, BR002 was only on SBRT, but here they allowed a wide range of fractionation, even patients with brain metastasis. So it was not an SBRT, but all kinds of dose fractionation were there. So to summarize, I would say that this is definitely showing some positive data, but we still need to have caution, because trial is small size, and it is oligometastatic site, as we know, is a quite biologically heterogeneous disease, and the differences in the endpoints also matter. And though it is a very positive thing, but we need to wait for the trials that would be looking at especially de novo subset, oligoprogressive subset, and there are various trials that are already ongoing, and we need more data, bigger trials, to make it as a uniform practice.
Nilesh, your thoughts on this trial, yeah?
So this is a very encouraging trial, and this approach has proved to be a very positive, with positive outcomes in lung as well as prostate cancer. But I thought that there were many caveats in this study. Clubbing all patients with metastatic breast cancer, we know, is not the correct way to think. The survival of ER/PR positive, HER2 positive, and triple negative is totally different, and clubbing them together is absolutely disrespecting the biology of this disease. I am in favor of considering this option in patients who got a induced oligopersistent disease, similar to the earlier study where patient has responded to treatment and remains to have stable disease, rather than an upfront oligometastatic disease, because there you really don't have an idea about the biology of the disease. And these are my two main, and of course the sample size was very small. The number of patients finally included were very small. We've had several negative trials earlier. I mean, while we are looking at SBRT alone, somebody might say, why not even surgery trials, it being included in this kind of a scenario? But this study does not look into the biology of the disease, and that is my main reservation. And I would not consider it to be a standard of care as of today. Even in a patient who responds very well to initial therapy, say 1 year of treatment and has residual disease, is it really going to make a difference giving SBRT to that is an important question. I understand that that's going to be very difficult to answer because we need huge trials for that, and we'll have to make do with whatever data there is so far. But as of moment, I don't think this is for all patients.
So basically, to summarize, this trial was the first randomized trial to actually show benefit in breast cancer. Quality of life was maintained, which is very important. We are worried when you're adding some excessive treatment. Like Madam said, it's a small trial. They could not accrue patients. Majority of patients had 1 to 3 lesions, bone-only lesions, and were HR positive. What makes me wonder is this definition of oligometastatic disease has happened in 1995. Gansham, why do you think this is still being debated? 31 years, we have not been able to prove whether we have to treat them properly with radiation or surgery for that matter.
So before answering that, so my take is that this trial is only encouraging for our radiation colleagues, right? To put the patient on radiation. Otherwise, the larger cohorts have failed. And by this time in last 10 years, the whole systemic therapy has changed. So every ASCO, every ESMO, so not only the HR positive, HER2 negative, HER2 positive, so all subsets have gone into a haywire changes. The whole, because is a systemic therapy has changed. So that's the reason. Otherwise, so only for a 70-80 patients so showing a positivity, so it cannot be a practice changing.
So
Yeah, I mean, I totally agree. But even as a radiation oncologist, I am taking this with a pinch of salt because it is definitely a very small trial. And what I agree with Dr. Nilesh, who said that it is very good in induced oligometastatic state, wherein you want to delay initial change of systemic therapy, and that should be an important endpoint to look at.
But Tabassum, so you'll be happy because you're at Tata, but it doesn't happen in a private practice. So it will be a different ballgame.
Yeah, but here we are discussing science.
Madam, if I can get you to this astro consensus, which defines oligometastatic disease as a state where all tumor locations are amenable to safe ablation with curative intent. How many of your patients in oligometastatic disease you're actually radiating with curative intent? And how many of them you're radiating, like how Dr. Nilesh has said, a patient continues to be in oligometastatic disease for a long time, and you're hoping to delay the next treatment? That is not curative intent. So where do you stand in this? Do you
So
go with this
actually,
astro consensus?
after the Saber Comet trial, it did impact our practice, and we started treating patients who were synchronous. I mean, without de novo upfront. So we did treat for couple of years with in that subset of patients, but now we are tailoring the need of SBRT based on response. So if the patient has had CMR, then it is, I mean, no need to treat such patients. But patients who do have a partial response, then those particular lesions can be targeted.
Fair enough. I think initially we were tempted because of the all retrospective data, which was quite flawed. And then we had, like what Madam has told, the Cyber Comet trial. Like Madam has clearly pointed out, only 18% had breast cancer. And actually, if you look at it in detail, there was higher grade of toxicity in that arm, including 4.5% treatment-related deaths. Now, that is quite a large percentage. There was this extent trial which did not prove any benefit, and the NRG BR002 trial where interestingly there was no benefit, and this was something which was very interesting for me. What the PI said was, I was really hoping that it would work. What I tell my trainees is that we have to be the most skeptical of our own work. We have to guard against our own bias, which nobody thinks they have, but all of us do. Practically in our practice, if somebody has responded very well, has had 2-3 metastasis, invariably we would end up radiating. Prasad, what are your thoughts here? How do you practice this?
So I fully agree with you. We always select those patients who are otherwise doing really well, and they are the ones who get into this oligometastatic treatment. And everybody wants to treat a patient who is likely to do well, and that is where the outcomes are also different. And I agree with Dr. Bishwas and that the evolution of systemic therapy is the one which has actually made this possible, and prevention of the next line of therapy or even treating a scan, it is treating a scan more than sometimes treating the patient or getting an overall survival advantage. The interesting question will be whether with this kind of data, if it is available with a new drug, what will be the oncology community's reaction in adopting that in practice?
And
Yeah,
the
fair
extent
enough.
trial was just on 43 patients. I mean, that was even
Yes.
smaller phase 2 data, which did not show
Yes.
any difference.
Absolutely. So I think this we have discussed. Madam, do you think this improvement in radiation techniques has actually contributed to the better results with this trial compared to the previous ones, or you don't
In
think so?
No, I don't think so because SBRT and the planning techniques are pretty standard, and no extra imaging was done or image guidance etc. was done, which was, I mean, presented in ISTO. That's what the authors had presented. But what is important was 50% patients had received CDK4 inhibitors in this study. But I don't have the specific details of the CDK4 inhibitors, although in BR002 they said that 95% patients receive systemic, but I don't know exactly what kind of systemic therapy, or was it only hormone therapy or targeted therapy. But in this study, 50% had received CDK4 inhibitors.
So, Gansham, if you can, or Akhil, you take this one. Which of these three patients would you actually use SBRT? A 53-year-old TNBC with a solitary liver met post 1 year of treatment, or a 65-year-old, three bone metastasis T3N2M1, or a 55-year-old HER2 positive with four mets, and she's been on 3 years of letrozole and abemaciclib, and now progresses in a plainless vertebral mets on routine imaging. Where is your use of SBRT? Hill, are you there?
I think we have lost him. You can take some. Can
Okay,
someone else?
can I just make a comment? So out of the three choices that you've just given us,
yeah,
I would probably give SBRT or consider some form of radiation in a situation where there is a hormone positive disease, good options of treatment being there, and when there is some oligoprogression. I think we all do that in practice. I don't think there is much data for it, but we do that in practice and we see it work. Would I give radiation to an oligometastatic site with the intent of being curative? I don't do that in practice. I'm not very convinced that really helps.
okay. Gansham, imagine a 65-year-old lady's ER/PR positive, T3N2 M1. She's got two metastases, one in the fifth rib and one in the seventh vertebra. How do you manage her? Do you give her just CDK4 inhibitor plus hormonal therapy, or do you do the whole thing? You give her neoadjuvant chemo, surgery, and radiate both the areas and then put them on hormones?
So fifth rib is mostly a traumatic at times. So so I'll treat this patient probably with the full chemotherapy, and then we'll assess. So I won't treat them as an oligometastatic, and we'll take palliative intent. So full chemotherapy, and then we'll see how it progresses.
Fair enough. Prasad, how would you manage such a patient?
So this is where the multidisciplinary team discussion comes in, right? And we once we decide on oligometastatic with a curative intent, I usually tell that I usually don't consider this as curative intent treatment. So if there are few metastases, it means that with the systemic therapy that we have, we are going to have a long-term outcome. That is how I look at it. But I have seen patients who get the works actually. Sometimes these oligometastatic patients get more treatment than the normal early stage breast cancers that they get.
Can I just make a comment?
Yes,
And
yes,
one of the
Nilesh.
limitations, of course, that has not been addressed in this trial Typically in HR positive patients who have received radiation for focal lesions, myelosuppression after that is such a big problem, and that actually compromises your treatment with the other systemic agents. I'm not
Fair,
saying that's the same for SBRT, but with conventional radiation that is there.
fair enough. I
Especially to
think,
the pelvis. If it is to the pelvis,
yes.
it can lead to myelosuppression.
Madam, I think you did make a point on this, but do you think that instead of looking at progression-free survival, if we start using, this time to next treatment as the goalpost or the primary endpoint,
Yeah,
do you
that's what
think
I
more
mentioned
SBRT would
also
be used?
previously. This will be a very valid clinical endpoint. In fact, in recently in Lancet Oncology 2026, they have published a full paper mentioning at least 10 to 15 types of endpoints that can be looked at, which included start or switch of systemic therapy-free survival, then polymetastatic progression-free survival, time to deterioration of quality of life. I mean, there is a full recommendation about selection of clinical endpoints.
So I think these are the patients who actually do well. A single met, bone only, small lesion, hormone receptor positive or HER2 positive, metachronous, that means comes after 2 years, and having a very good performance status. The last point on this is,
Last minute, KP.
yeah, how do you actually, now that you're going to use more and more SBRT, Nilesh, how do you sequence or how do you manage these patients? In the sense, for example, somebody is on a alpelisib, for example, and your patient is on treatment, or patient is on immunotherapy and you think you want to do SBRT. There are certain now thoughts that, do you stop those systemic therapy? Do you continue it? How do you manage?
So that is a challenge. Many of these areas. Sorry, was that for somebody else?
No, it's first for you.
Yeah. So that is a challenge. While there is enough data to suggest that it's okay to give immunotherapy along with radiation, my experience has been that many of my radiation oncology colleagues prefer to hold on the immunotherapy while radiation is being given. And as I mentioned earlier, giving radiation with many of these CDK4 inhibitors sometimes is a challenge, especially if patients are heavily pretreated, have a lot of bone metastasis. That definitely is a challenge with chemotherapy also.
But there is no need to postpone more than hold for more than 1 week.
Correct.
I guess 5 half-lives are done within 1 week.
Correct.
Yeah, Prasad, what is your thoughts on this? How are you managing it?
The use of concurrent, is it?
Yes.
So I don't think if it is SBRT, there is a lot of concern in our usual management actually. Usually it is pretty okay to continue.
So what we should not give is like a cytotoxic chemotherapy, including capecitabine. So that should be the absolute contraindication. Otherwise, rest can be taken.
KP, you have to conclude.
Yes. Okay, so I will conclude by saying that, we have not discussed the sequencing of ADCs because I don't think any one of us have come to that point yet. So I think we will end there, and I thank you, Dr. Sahu, for this wonderful opportunity. Thank all the panelists for this also, and hand it over back to Dr. Sahu.
Thank you. I really envy your back support, KP. So what we'll do is the last part of it. We have saved the best for it, and I think I'll not waste more time. I'll just invite Dr. Atul Batra. He's in AIMS New Delhi, and he'll be picking. He's speaking and critically analyzing the top 3 picks of what he feels is probably practice changing or something that's very exciting that could change practice in the future. Atul, all yours.
Thank you, Dr. Sahu. I think I'm usually the last one between lunches, but today I'm the last one between the sleep, so I'll stick to time. And,
No, you can because the people who are left will be interested ones. So it's totally yours.
Thank you. Give me a minute to just share. So are the slides visible? Just a confirmation.
Yeah.
All right.
Please carry
So
on.
my topics from ESMO 25, just one slide. How does it come to the top? There were many interesting abstracts, many promising ones. But for this session, we took those abstracts which kind of have already proven to change the survival or a very much validated surrogate. They have a potential to change the practice or have already changed the practice meanwhile from ESMO and changes the understanding of disease in case it doesn't meet the first two criteria. A disclaimer, we are not discussing financial toxicity and access issues here. Otherwise, I will be self-promoting and I'll be putting the Planet study on the top. I've not included it here. So the first one, and I think this is the unequivocal abstract that I would put on top, which is Destiny Breast 05 presented at ESMO last year. And at least I have started using it in practice. There are certain issues that we will discuss as we move through. But just quickly, who are included? Many a times we have discussed this in the panels that I moderated. We often forget that the inclusion criteria was pretty much for only those with high-risk patients. Who were these high risk? These were inoperable early breast cancer. That means they were either T4 or they were N2 to N3 if they were less than T4. This should be very clear. Or if they did not meet this criteria, on the pathology after surgery, they have to have node positive disease. To begin with, they could just be T2N0, but if they receive PTCH, ACPTH, whatever, and they have any node positivity after neoadjuvant treatment, these are the patients who were included in this trial. Very simple design, no complications here. You have a control arm of Catherine, where TDM1 is for 14 cycles, and then an experimental arm of Enhertu for 14 cycles. Quickly about the sample size. So this was, if you see here, the assumptions, I was very happy with this trial with the assumptions that were made. This was 83% in the control arm and an improvement by around 5% in the Enhertu arm. So 83 is what we expect. If we go back to Catherine, we'll find that it improved from 77 to 88%, but those were all risk. But here it was only those with high risk. So we expect them to do less well than those with Catherine, 83. 5% DFS is acceptable. So hazard ratio was 0.675. Do you want me to discuss the sample size here that we were discussing earlier, kind of with the hazard ratios?
Yeah, sure. That will be nice.
So we were discussing if the hazard ratio assumption is 0.675 here, vis-a-vis 0.8, what will happen to the sample size? So we all know that for sample size calculation, there are a few things that matter. One is absolute delta between the control arm and the experimental arm. Dictum is, if the delta is higher, your sample size goes lower. Alpha means your p-value, which you set a priori. If it is lower, your sample size increases. You keep it to 0.05 vis-a-vis 0.1. 0.1, your sample size would be lower. Third is power, which we classically keep it at 80%, but industry will keep it at 90-95% because they do not want to miss an effect. So that would be a false negative study. Higher the power, higher the sample size, right? So delta, alpha, beta, right? Again, delta is the difference between the two arms. So it is here 83 versus 88.2% and indirectly represented by hazard ratio. So if the hazard ratio was 0.5, the delta would be higher, right? It would be say 83 to 93, just an example. 83 to 93 would be hazard ratio 0.5. So this means that your sample size would be lower than this. But if you have a delta of, say, hazard ratio is 0.8, your delta becomes 83 to 85%. That means your delta is getting smaller. That means your sample size is going much larger. I think alpha, beta we know, so we are not going into that.
Okay.
Lower the alpha, higher the sample size, higher the beta. So typically, to remember, I think we can keep what industry does is a higher sample size. They keep the delta smaller because they don't want to miss the effect. They keep alpha at 0.05 or even lower, but they keep power classically higher to make sure they are not having a false negative study. Is that clear now?
Yeah, much clearer.
Perfect. So nothing in this slide that we need to see. We know what is happening. So few comments about this slide. The debate about anthracycline still goes on, even with the pertuzumab, trastuzumab penetration of 80% compared to catherine, which was 20%. Here, anthracycline usage was still 50%. So this world clearly remains divided on anthracycline, and it is okay to use either. This was a high Asian population study. So what this would mean is when we'll have an OS outcome of this study, there may be some drug access which is not here in Asia, and we may see a higher OS difference. That we'll keep it for another day. But just keep in mind that anthracyclines are still not out, and overall this was a well-balanced study. Now the delta here was 8.7%. So if we go back to assumptions, it was 83% and bang on. The control arm is 83.7%, right? And from 83.7, it actually much exceeded the expectation. It went on to 92.4%. Remember, this is a high-risk group, and having an improvement here of nearly 9%, it's pretty amazing. It straight away calls for an approval. Some things to look at: Kaplan-Meier curves. So we started with 800. At 3 years, here the median time was, I think, 29 months. So we are analyzing more than median, and here the at-risk population, this is something we should always look at. Where are we seeing the delta? A classical dictum is we should not be looking much beyond when less than half of the patients are left. Here, there are almost less than 1/8 of the patient. So we need definitely a longer term follow-up is required. Only 120s were at risk at this point. So an ideal assessment would be somewhere around 26 months where the gap is narrower. But this was event driven, so nothing against it. Subgroup analysis, everyone appears to benefit. And those crossing unities, again, we should not be overlooking into this. I'll tell you why this happens. We all know why this happens because of these smaller numbers. So here, if you look at, there are just 11 events versus 15 events. One event here and there, and this whole thing would just change. So this subgroup analysis is actually not powered enough to read enough. What is more important to see that they're all consistently lying on the left, and there is no interaction. So interaction is the right way to check. Rather than looking at these hazard ratios individually, we should look for interaction, which is more important than subgroup hazard ratios. One thing that is being oversold here is CNS metastasis. So if you look at the total number of events, these were double in the control arm, 51 versus 102. So you'll see this is our most important block, the distant recurrence one, 77 versus 42. Of this, most of the events were 52 versus 25, so nearly half the number of non-CNS events. But CNS was 25 versus 17. There was a reduction, but we cannot say with clear dictum that it decreases the CNS events. We need to look at more number of events, and this was not powered to look at anyways that ways. There were higher otherwise local, regional. So these are 6 and 5, 11. These are salvageable patients, and 6, 17. So if most of the effect was lying here, then I would be worried about the drug use rather here. So most important is distant recurrence, which makes a lot of sense. DFS, just removing these all secondary were kind of aligning with that. OS is still immature, and then HER2 positive OS is going to take a lot of time to report. DFS is a very, very well surrogated marker for breast cancer because here we are looking at a cure getting into a metastatic disease. So with a hazard ratio here in the primary outcome of it is 0.47 and an absolute difference of around 9%, I am pretty much convinced to use this drug in most of our patients who kind of are eligible to receive this drug. Overall toxicity was kind of similar to what we know. Around 28% could not receive the full 14 cycles compared to 24% in the TDM1 arm. And a couple of more points. There were 2 deaths due to ILDs despite their strict monitoring. So we are going to see some ILDs around 10% overall. And mortality here, although it was 2 out of 800, but this was clinical trial setting, it may be higher. Radiation was actually, it was left to the investigator. They could allow it to be used concurrently or sequentially. And almost half and half was seen. So overall, it is very similar to what was seen in TDM1. So it doesn't look like there is concerning. These are the 2 deaths that happened in the trial due to ILD. So they concluded everything was positive, and everything is fine. some takeaways. This is practice changing, but are all residual disease do they merit Enhertu? No, we will stick to the clinical trial criteria. But within the clinical trial criteria, are all high risk similar? So suppose we have a patient who was T3N2 to begin with, and now has a residual disease of 0.5 centimeter in primary and no nodes. This patient would have a much lower risk as compared to those with a 10 out of 14. But we can't, dissect so much and get a very, very specific clinic patient into the trial and a trial for every clinic patient. So overall, we have to agree that this is effective, this is there, and this is likely to be used in clinics. And monitoring is needed for ILD. So this is about DB05. If we want to kind of have any comments, questions here, we are happy to take them.
Atul, Amish here.
Hi.
Hi. Sorry, this takeaway, the last point what you have written. See here, after DB03, I would have been surprised if this study would not have been positive. But the delta, whatever you explained based on the sample size, it is still narrow as compared to TDXT versus TDM1. So I would further like to ask you a specific question, which see TDM1 also did well in this particular study. Of course, the delta was higher with TDX. Which are those high-risk patients where TDM1 is sufficient, and which are those high-risk patients where TDM1 is not sufficient? Where have you changed your practice, and where would you confidently risk ILD and 2 deaths and not give TDM1? I would like to know the specific clinical scenarios from you.
So if you look at delta, to me is pretty amazing. 9% DFS going from 83 to 92%. 9% absolute. I could not have
I'm not
expected
doubting.
more than this.
I'm not doubting
So
any results.
first,
I'm
and
just trying to find
TDM1,
out, Atul.
yeah.
Sorry, Atul. I'm just trying to find out who are those 83% in the TDM1 who can safely be continued to be given TDM1 in our practice, and who are those patients where no TDM1 but only TDXT.
So TDM1 would go to those who first were not eligible for this trial. Within this trial eligibility, it is difficult to kind of dissect. If you look at the forest plot, you will see that nearly everyone has benefited. If you wanted to look at ER positive versus negative, it was clearly seen in both, and they're pretty far away from unity, not even reaching there. If you want to see whether they were operable or inoperable, it is still not there. But if you have to choose one, like if I said they were initial one, they were inoperable, but they have an excellent response, and there is some kind of 0.5, 1 centimeter disease, but node is negative. Node positive would straight away kind of take me. I'm still one of, although I'm not that old timer, but node positivity is kind of a real then that way there is a prognosis dip clearly when there is node positivity happening there. If the patient was inoperable to begin with, becomes node negative, and there is kind of a minimal residual disease less than 1 cent. This is again, I'm saying out of nowhere. I do not have any data to back with me. So most patients who kind of fit this criteria, I would be happy offering them with strict monitoring, of course. And those who do not kind of fit into this would obviously go to TDM1.
Got your point. Please continue. Thanks, Atul. Thank you.
Thank you. Did you have anything else in mind, kind of, in your practice?
No, so I am not fully convinced about the subset of patient where we would give TDXT, Atul. I'm just trying to think through. Tarini also has written, it's very difficult to answer. See, the control arm still is doing well in majority of the patients.
Atul still has to share his screen. He has not completed his. He has not completed. Yeah.
Acha, okay, sorry, please go ahead. Yeah, Tarini ne
No,
bola chup kar
Amish,
Amish
you carry
karke.
on. I was telling Daud that Atul still has to carry on. He has not completed his talk. That's it.
Acha, okay.
So we know we are over-treating, but we are over-treating in all adjuvant setting. We treat ER positivity for kind of 3%, 4% benefit. We were happy giving Abema for 7.6% with an absolute OS of 1.8%. But HER2 is, we are moving from 83 to 92 is a big leap. And when we looked at, if we look at Catherine was also a smart trial. The initial trial reported around 11% DFS benefit, and then later on it showed almost 14%. So the benefit actually increases. So I'm very much positive that as we go on and the data matures, this is going to further increase. The only thing is that with Catherine, we also have overall survival benefit now in tune of around 5%, but this is very, very immature about overall survival.
Hello,
But for adjuvant studies,
let's accept that. Hanji, Hanji. No, sorry.
Atul,
No,
please carry
you
on.
are right. Atul, there is no, with 120 events only at risk, 120 only at risk in both the arms. I have my doubts whether delta will further diverge. But
no,
you
no,
may be
this would
right. But
increase.
you may
No,
be right.
at-risk would increase as the follow-up increase. So
Agreed,
120
agreed.
have reached there because the follow-up is less. So as we move forward in next, we will see this happening
We will
every
see.
ASCO or
Anyway,
ESMO.
go ahead, Atul.
So yeah.
It's really
Atul, please share
interesting
your
to hear
screen.
all this from you. Please go ahead. Sorry.
Yeah, usually I'm the negative one, but that's why this was the first trial of my choice. And the second one is kind of, I've kept
Can you please share your screen once
03.
again, Atul?
I have
You
to
need to
share it
share your
again.
screen. What they have done is they have taken you out. So please reshare.
Okay, where is my widget? Give me a minute.
Sure,
I'm
sure.
still figuring out.
And back team, I will tell you when to stop sharing.
Okay, I'm still not able to find out where is the sharing.
कल से तारिणी तुम्हारा सब कुछ सुन नहीं रहे हैं तुम्हारा बैक टीम.
हाँ वही मैं देख रहा हूँ मेरे को क्लास लेनी पड़ी. He felt because discussion started it was over, so that's why he just please start.
So
Make it full
this is
screen.
the second one.
Yeah.
So the second one is kind of, these two trials were very similar, Ascent 0 through 03 and then Tropion Brez 02. So there is some kind of bias also in choosing these two, because I'm actually, we are treating almost now 10 patients with Dato-DXd in the first line in a PDL1 positive subset, which is Tropion Brez 05. And there are patients who are kind of going on for more than 18 months in the first line PFS, which I had never witnessed earlier. So this is kind of, that's why it's a second pick. But Ascent you see is prior to Tropion because of the reasons that were earlier discussed. They were good trialists, they allowed crossover. But we also have to see that why Tropion Brez 02 did not allow a crossover. So if you look at Dato-DXd, there is no trial in the later lines. It directly came from the pooled data of all the tumors straight away into the first line. So they did not have any data that suggested that Dato-DXd would be clearly effective, unlike sacituzumab govitecan. So sacituzumab govitecan is also a story of delayed drug development. You would remember sacituzumab govitecan that we have been reading it for a long time in the later lines, where it took them years to get in the first line, and still their maturity is less than Tropion Brez 02. Whereas datopotamab deruxtecan is a much recent drug, and still it has kind of reached earlier than sacituzumab govitecan. So we now have a third drug on the block as well, and we will see results from Trophuse 11, which is kind of similar to Ascent 04 and Tropion Brez 05. That is PDL1 positive subsets in the first line. So I will not go too much into the details, but just few differences. One, crossover was allowed, and second, they allowed a doublet that was already discussed, and there were patients who were recurrent within 0 to 6 months. This was 15% in Tropion Brez 02. So this is a significantly kind of bad patient subsets who do not respond to anything. And prior treatment was more or less similar. More patients received capecitabine here, but prior PDL1 is just 4%, 5%. As we discussed, these were the problems. Now, here is what we look at the differences between their primary outcomes. They improved progression-free survival, but if you look at their control arm, there were differences in the control arm. Ascent 03 allowed gemcitabine and carboplatin doublet, and overall their progression-free survival was near about 7 months, and it improved to 9.7 months with a hazard ratio of 0.62, 0.57. Overall, very, very similar results, just certain differences, what we kind of have been seeing with palbociclib, ribociclib, abemaciclib. Some differences here and there. if you look at prima facie data with Dato-DXd is somewhat better, but we have to keep in mind that the trial inclusion, everything was somewhat different. And if you look at Keynote 355, here also it was 5.7 months, which was again very similar to what they had in Propion-Breast-02. Subset don't reveal us anything except for one thing. If you look at patients who were chosen for taxane, probably with a lower disease load, vis-a-vis gemcitabine carboplatin had somewhat better, but again, very small sample sizes, not too much to go into detail. Response rates are somewhat better with Dato-DXd with a different patient profile here. And we have overall survival data because median follow-up is higher here and it didn't allow crossover. So it was expected that we'll get a 5-month. A 5-month would not matter in certain diseases, but a 5-month in triple-negative breast cancer does matter a lot. And one more interesting thing, if you look at patients who were within US, Canada, Europe, and I mean, they had access to better drugs and further trials, they actually did not do better with first line as compared to other geographic regions. So this is the kind of NESD in second line. There was 53% here, 30% actually received even in Propion-Breast-02, but this was much higher in the ASCENT-03. Differences, neutropenia, neuropathy, and GI toxicity are 3 problems with sacituzumab govitecan. It is day 1, day 8 regimen. And I don't think it has ever included India in their registration trial. So we are unlikely to see sacituzumab govitecan, but its patent would expire in 2028. So we would see biosimilars kind of coming earlier, but Dato has involved India, so it would be marketed earlier. Dato-DXd is an easier drug as compared to sacituzumab govitecan. Trial data also suggests, and a limited experience of whatever I have also used also suggests the same. 2 toxicities are very typical of Dato-DXd. One is mucositis, and it is usually manageable. DEXA gargles and general hygiene works. The other problem that we have not seen earlier with other drugs is kind of ocular surface toxicity. This can be challenging at times. I mean, we are struggling with a couple of patients where the kind of corneal ulcers they have developed, they have been dose reduced twice, but still it is being a nightmare. So this is something we'll have to learn with datopotamab deruxtecan as we kind of start using it later. There were few deaths with sacituzumab govitecan, mainly due to febrile neutropenia, but no deaths with datopotamab deruxtecan. So these are the basic differences between the 2 drugs. They are likely to be approved. Lot of unanswered questions, and with those Isabrin kind of coming in frontline as well, there is a study that BMS has opened, and in the PD-L1 negative subsets, it has also already come to India. So that is kind of will be more interesting to see what happens to Isabrin versus these ADCs. There's a race between 3 TROP2 ADCs, sacituzumab govitecan, tirumtecan, and then datopotamab deruxtecan. And it would be tough. It would be like Palbo, Ribo, Abema, the first mover advantage, the first biosimilar advantage would be the key things that would define, and the toxicity. The results, I feel, more or less are similar in both the trials. There's nothing much to choose apart from toxicity is extremely important. Day 1, day 8 kind of versus day 1 only. These are the critical differences between the 2. So these are certain improvements that have happened in metastatic TNBC in the first line, and they came on the second spot. Should we discuss them here and then move to the last?
I think we can go to the last and then
We can go to the last. So the third one was kind of difficult to choose. Victoria, there were so many things happening with the third space, Serena 6, Victoria, and so many studies in the second line as well as Isabrin. But I think Optima came to my mind because this is something where we have kind of always been worried about more than 3 nodes and premenopausal subset. In the end, kind of it got a little not very encouraging. We'll discuss as we go forward, but a very good design. I mean, see, these patients were blinded to randomization, whoever received chemo followed by endocrine. How were they blinded? It took me a while to understand. Maybe you would have understood it earlier. So they were initially randomized to either control arm or test directed arm. So this is not like a RX Ponder or Taylor X where they took scores of less than 60 and then randomized to ET versus chemo ET. No. They took all the patients, they randomized to treat them with a strategy without Prosigna, straight away go to chemo endocrine, everyone, and use Prosigna, and at a lower score, just endocrine, and at a higher score, you give them chemo followed by endocrine. Now, how would they be blinded to randomization? So basically, patients were randomized here. They did not know which arm they went into. Those who were randomized to chemo endocrine alone went on to receive chemo. Those who had Prosigna and had a lower score were told that you have a lower score and got into endocrine. But those with high score or randomized to control arm did not know which arm they were. And this is extremely crucial while doing such studies, because the kind of ascertainment bias is what we call them, the kind of imaging frequency, how are you detecting them, recurrence, because this would be a long study in ER positive, 5 years, 7 years. How frequently are you doing CT scans? If you know that the patient is in Prosigna arm, you may be just imaging them less frequently to get a better result. But this was the most important part of this trial. And this was also one of the factors that it got into top 3 here. The patient population, we know this was more than equal to 40, even if they were premenopausal, node positive mostly, and if they were node negative, then minimum T size requirements were there, and no patients with neoadjuvant therapy. Again, some statistical design. The non-inferiority hypothesis here was 3.5% margin. Now, to some, this may be a lot, right? Because sometimes when we speak that the benefit of giving chemotherapy here would be around 3 to 5%, and an absolute non-inferiority here was taken as 3.5%. From randomization till per protocol population, there were a lot of patients who changed their mind. The first dropout was who got into the control arm. They went out. Then there were patients who were allocated to certain arm. They dropped out. So it is kind of similar to what we do see in clinics as well, that a patient with ER positive 1, 2, 3 nodes comes to me. I tell them, you need chemotherapy, goes to someone else, does oncotype DX, a higher score, still the patient doesn't want, moves to a third physician. So they'll keep changing physician till they hear what they want. So some dropouts were there, around 5 to 6%, which is not insignificant. So overall, this is crucial that 2/3 of the patients overall, they had a score of less than equal to 60. So most of the patients would actually have a lower score. Premenopausal were 38%, not a minor subset. Now, what got here, which was not, 4 to 9 lymph nodes were underrepresented. We don't know the further breakup. I would like to see how many patients had 4 and how many patients had 9. Because a patient with 4 lymph node is more likely to kind of have this treatment option, and a patient with 9 lymph nodes, I would not still be very comfortable kind of omitting chemo. We'll see the results. 30% also had a grade 3 tumor. So if you use Predict Online, grade 3 will change just everything, the benefit of chemotherapy by a large margin. Average age was 55. And here is the number of events that happened. So if you look at overall events, here the primary was invasive breast cancer free survival. How is this different from invasive disease free that we all say about? So invasive disease free would also take non-breast primaries, second primaries that would happen in due course of time. This would exclude that. So which would also make sense that there is no role of chemotherapy or anything in preventing a second non-breast primary. Right. So this is a more specific one. So overall, if you look at the number of events, it is 7.2% in the control arm, who all went straight away to chemo versus chemo followed by endocrine, and test-directed arm, 7.3%, who were decided based on Prosigna. And then we had, if we take patients who were less than equal to 60, only chemo versus chemo plus endocrine, here the number of events was 68 versus 76. Very, very similar. But mind you, currently the overall median follow-up is just 3.9 years. And here, if you look at the benefit of chemotherapy, it is 1.5% in complete per protocol patients. And if it take is less than 60, the benefit is 1.2%. So it is actually much lower than what we kind of hypothesize the non-inferiority as well. But the number of events we have to understand is far too less to draw out anything. 40 versus 49, still a very brave trial, I would say. But this is the population I would be interested in. PN2. We know PN1 from RX Ponder, at least for postmenopausal, half of this population is already clear. So what were the questions that I would be interested in between high age more than 40 but premenopausal N1 to 3, which was not clear in RX Ponder, and of course PN2. But PN2 is kind of just 260 patients and 240 patients. Number of events just 20 and 17. But a lot of events would happen in the future. We have seen those graphs where the N2 diseases kind of followed up till 15 years. The number of events would go to as high as 50%. So I would expect at least 70 to 80 events happening here in this group in each arm, and then it would be kind of interesting to see. Still, it would be underpowered to take a message out of this specifically for N2. So it still kind of doesn't solve that dilemma much to my mind. It just helps us in patients who are not willing. I mean, anyways, they are not going to take. So I don't know where it helps. Even for premenopausal, it is like 25 events versus 26. 5 events here and there, and things just change. 40 to 50. That's still very, very immature. But overall thing is that this was a brave trial that it took up to 9 lymph nodes. It's a cheaper test than Oncotype DX for sure. And I would kind of eagerly await for the results of this trial to get mature over next 3 to 4 years. So I think I discussed all these points. So long-term follow-up would be the key for me regarding this trial. I would like to thank Dr. Sahu once again. Thank you very much, sir, for inviting me here, and happy
Anyone
to
has some
discuss further.
important thing to say to Atul? Any good questions? Amish, you're
Yeah,
unmuted.
thank you. I have few questions, Atul. As always,
Yes,
is it easy to
yeah.
ask questions?
No, it's lovely to discuss actually. I mean, these
हाँ,
are so many things that
so
happen that.
so first of all, thank you for pointing out Optima. मैं कल से सुन रहा हूँ, लेकिन I never thought that first they randomized into standard arm and then they further sub-randomized. I think this is a very something different and unique. So in that, I wanted to ask you, Atul, patients who were randomized upfront to the control arm, then I saw in your flow chart that at the end of the treatment, ROR score was done.
Right.
And you said 66% of the patient had ROR, I think, less than 60.
Less than 60, right.
Do they have the further breakup in that control arm of the patients who are less than 60 and more than 60? And how did they fare? Just for my knowledge.
That was there. That was presented also. We do not still have the complete paper one, but this was included. So here they did the Prosigna once this was done, right? And they have the score. So it was similar in both the arms. If you look at the distribution was 66% here and 67.8% here. But here everyone received chemotherapy in the control arm.
No, I know. I just wanted to see whether ROR makes any difference in the biology of the disease when chemotherapy is
So if
given
you
to
see
both.
here, control ROR less than 60. These are those patients whom you are talking about.
Yes,
Control
yes.
ROR less than equal to 60, test directed ROR less than 60. Here the number of events are 68, 76. Still far too less.
Right. So they have compared basically
They
both in
have
the
compared.
control and the test directed. This is interesting. So keep this table. So 1421 out of 2094. These are the patient who actually were the real test samples.
These were the real test samples who kind of who were randomized to test directed arm, and then they had a score of less than 60, and then they went on to receive BT.
Correct. Yeah, matlab, agreed. I think a very interesting trial. We should wait for some more results before we, as you rightly said, some more events in each arm. You are happy yourself with non-inferiority of 3.5%, Atul, or you would have kept?
Was not, but I was not expecting these curves to be like that even at this point of time. Right, the curve is just over one over the other. 1.5% is like nothing. 3%, 3.5%, I wasn't happy, but this is kind of overshot my expectation. I was expecting some difference because these are still all node positives, still patients who are between 40 and 50. So there are still high risk patients, and it's not that the 3.9 year is the median follow up. Still we didn't see much of a difference. So very, very interesting, this thing. Just interesting. We still need to kind of wait for this to pan out. ER positives, and we do not know again all of them received OFS. But again, we will keep discussing about CDK4/6 and all those things that have happened. Meanwhile, we cannot have them in the trial. So these patients were, I mean, this trial started in 2017. Far long back. Again, we cannot expect them to have all those things.
I agree. Tarini, if any other has any questions, because I have one question on Ascent and
please,
Tropion.
you are the only one who can ask questions. I've stopped everyone else.
Okay, Atul, it's really interesting, Atul, the way you have dissected it is something different. I loved all the three trial dissection of yours. In Tropion and in Ascent, both the trials back to back you have presented. I just wanted to ask you only one question. In fact, two questions, sorry. Open label. In an open label with PFS as the primary endpoint and a very modest PFS benefit, how much is the censoring versus bias when you are looking at such modest difference in an open label? Because both were open label.
Right. It is
And my
difficult to
second
have,
question
I
you can
mean,
answer together.
अगर कोई बोलेगा कि इसको blinded करो, the moment patient develops corneal toxicity, you would know. I mean, there are sometimes
सबको corneal toxicity नहीं होता है, Atul.
But you will get to know on the first cycle that this is dato. There is no way. And still, I mean, sometimes it is hard to do those. But I agree with your point that with open label, it is sometimes censoring can lead to, but a difference here was 10 versus 5.2 months. Not, I mean, I would not call this modest 10.8, 5.6 again. TNBC going on to 20, 25 cycles in first line of an agent. I mean, I have those 10 patients on Dato doing extremely well, touchwood all the way, but with CNS metastasis. And I mean, this is again anecdotes. 10 patients should not make a statement that this is pretty effective. But we have almost never, what do we see in metastatic TNBC? Most of the times your first scan is partial response and second time it is progressive disease. At least in my clinic, I see the same. And many a times even the first scan is PD and then you kind of start doing those things. The only thing is they didn't allow gem carbo, which was kind of, so Dato was a little shoot trial if Astra guys are not around, because they were kind of, they wanted this difference to enlarge as far as possible. The response rates would enlarge if you do not allow a doublet. The PFS would enlarge if you do not allow a doublet. So these were two things which were, but they allowed patients within less than 6 months. Crossover, they could not have allowed. This point, I don't take it very straight away, because, but Ascent 03 were pretty nice guys. They allowed crossover and they covered for it. I mean, normally they would allow, but they would not cover for it. But here it was covered by the trial. So that was pretty nice of Ascent guys.
I agree on that point. I see the delta of Ascent is 2.8 months.
2.8.
So that's where I was talking of open label and censoring.
Yeah.
But so my second and last question for today is both the trials were done in PDL1 ineligible patient.
PDL1 negative, yeah.
If you see the, no, they have written PDL1 ineligible. Basically, it can be.
So if you see 0.4% or 10,
but if
90%
you see,
and 99% were PDL1 negative.
Correct. So if you still see the curve, which is, even if they are PDL1 eligible, I see with Tropion, 10 months is even slightly more than the SN04 control arm.
Ascent 04, so this would be a CPS, that Ascent 04 would be a CPS more than 10.
Correct.
Right.
What I'm trying to say is that are these ADCs, they are bypassing the PDL1, PD1 interaction. It is just hardly 10% of the patients who are PDL1 positive, but I'm just trying to think through because these curves are as good as you can see in TNBC.
So I'll tell you the Tropion Breast 05 has an exploratory arm to answer your this thing. So they have Dato Durva as an experimental arm, chemo Pembro as the control arm, and then the third arm is just Dato DXT. I do not know how it got a regulatory approval. So that arm is not receiving any IO despite being PDL1 positive. So there we will see the effect of pure Dato DXT alone, but that's a small 75 patients arm. There we will get to know what happens irrespective of PDL1. Without Pembro, are we also reaching there in PDL1 positives? So that would be answered by TV05.
Interesting. Good to know
Yeah.
that others are also thinking the way we think.
So this is now the regulatory kind of approval. So Astra kind of pitched in that they want Dato plus Durva as the experimental arm. Now, if you see, there are two experiments here. One is Dato, one is Durva.
Correct.
Right. Durva is not approved. So that is why FDA pitched in, and FDA asked that you need to have a Dato alone arm or a Dato Pembro. At least Pembro was approved. You cannot have two experimental arm and then you sell it as a package that if you take Dato, you'll have to take Durva. So that will be answered because Dato alone arm would also be there. Although it would be underpowered, like we were discussing in Victoria time that one of the arm cannot be
Victoria
compared,
one.
but still you
Yeah.
can get a broad idea what's happening. The whole idea of having that arm is to get an exploratory analysis.
Absolutely right. Thanks a
So I
ton,
think
Atul.
we
Yeah.
have to call it a day. So, so last thing, I really thank all the faculties, all those who joined in for 2 days. I know nothing much has happened in this ASCO. Great that we can call for breast cancer, but still, I think there are very good discussions for both the days, academic discussions, no company interference, and that's what is lovely about these deep dives. I really thank all those who joined in, the back team support, Tarun and his whole team for both the days. And I will just ask all those FIFA football lovers. It's just 2.5 hours away from the first match of Mexico versus South Africa. Have your dinner, relax, and 12:30, switch on your TVs or mobiles, whichever you are, and you will have your first match of FIFA 2026 on. So with that, I say good night to you and let us meet somewhere very soon. And all of you have a great year ahead.
Thank you, Tarini. Thank you so much.
Thank you.
So thank you,
sir.
Dr. Sahu. Thank you so very much for this. And thank you, Daud, Pooja, Manya, everyone from the organizing team. And we say thank you, goodbye, till we meet again. So support